Okay. Assalamu alaikum, guys. My name is Rida Shahab. I'm a second year medical student, and today, alongside my colleague, is Adam Al Khawli, who's also a second year medical student. And inshallah, today we'll be teaching you the OSPE for gastrointestinal block. This OSPE review session is a bit long because we tried to be comprehensive of everything that has been taught to you guys. So we would request you guys to share your questions in the chat instead of unmuting your mic because it's a long session. We try to compress every information that we got as much as we can. So if you have any questions, please feel free to write it in the chat and we're going to address it. And let's start. Just 1 second. Okay. Bismillahirrahmanirrahim. So these are our table of contents. We're going to do the oral cavity, tongue, glands, pharynx, larynx, and the esophagus. And then we're going to start with the stomach, pancreas, small intestine, large intestine, anterior abdominal wall, anal canal, rectum. Then we're going to go to the liver, gallbladder, ultrasound, and anatomy, and that's pretty much it. There's going to be practice questions throughout the OSPE review, and we're going to give you some time to solve them. All right, so let's start. Bismillah. We all know how the digestive system works. So you're going to be consuming your food. It's going to go down to your esophagus, then to your stomach, small intestine, large intestine, and then the rectum and the anus. Before we start, this is just a general structure of the gastrointestinal tract that I want to put out for all of you because it can be a bit of a confusion. So we have the mucosa, the submucosa, the muscularis externa, and then adventitia and serosa. So mucosa is basically the uppermost layer in the histology slide that you see. There's going to be the epithelium lining the organ. Then you're going to have the lamina propria and muscularis mucosa, right? Submucosa is where majority of the glands are going to be found, with the exception of your stomach, because stomach glands are actually found in the mucosa. We're going to cover it, so don't worry. We also have a muscularis externa, which is arranged in two fashion. So there's inner circular and then there's outer longitudinal layers, which when you see in the histology slides, it's going to be more clear for you. Adventitia and serosa is the layers where you're going to see blood vessels and other structures. This is the point which I mentioned. Esophageal glands are usually in the submucosa, whereas the gastric glands, which are your stomach glands, are usually in the mucosa. Okay, so let's start with the oral cavity. Before we go on, can you guys hear me well? Is my audio clear?
Yes, it's clear.
Okay, so we all know that the GI begins with the oral cavity. So anterior 2/3 of the tongue lies in the oral cavity, whereas the posterior 1/3 of the tongue lies in the oropharynx. Now, oropharynx is the part of pharynx. There's 4 parts that we're going to cover. Oropharynx is the part that lies right behind the oral cavity. That's what gives it the name of oropharynx. The uvula, which you see in the picture here, is a small fleshy structure hanging at the back of the throat, which plays a role in speech, swallowing, and it also prevents food from going into your nasal cavity. And this uvula also helps in saliva production as well as triggers your gag reflex. Okay, so the tonsils are very, very important to know. These are one of the major questions that doctors usually ask in the OSPE. So know their locations and their names really well. Okay, so we're going to start with the palatine tonsil, which is at the lateral side of the oral cavity that you can see here. I hope you, wait, let me just change the color of my, okay, right here. So those are palatine tonsils, right? And in the cross section here, like this is the cross section. If you look at the cross section, the palatine tonsils can be seen right behind the posterior 1/3 of the tongue in the oropharynx. So we said oropharynx is, posterior 1/3 of the tongue lies in the oropharynx. So these are the palatine tonsils here, okay? Because this is your posterior 1/3 of the tongue and this is your oropharynx here. So this right here is your palatine tonsils. Okay, we're gonna cover the tubal tonsils, lingual tonsils, all in the pharynx. So it's gonna be all clear once we go in order. So don't worry about that. For now, just know that the palatine tonsils are lateral to the oral cavity. Okay. We also have the intrinsic and extrinsic muscles of the tongue, which are supplied by the hypoglossal nerve. Now, can someone in the chat tell me which cranial nerve is hypoglossal? Guess took this in FND. 12. Thank you. It is the 12th nerve. So all extrinsic muscles of the tongue as well as intrinsic muscles of the tongue are supplied by the hypoglossal nerve. Okay. The anterior two-third of the tongue, the swallowing is voluntary, whereas the posterior one-third of the tongue, the swallowing is involuntary because the food has already reached there and now you cannot control the movement of the food. It's just going to go down the tract. Okay. The palatine tonsils, as we said, are in the oropharynx. These are the tonsils that we talked about. It's posterior one-third. Okay, moving on. This is just a labeled picture here for better orientation. This is the oral cavity, and that's the tongue. Oral cavity proper is everything that you see inside, which is, wait, I think there's a picture right here. This is oral cavity proper, which is everything that's inside of the mouth. That's called oral cavity proper, okay? Moving on to this picture here. You can see the hard palate. This is the hard palate of the tongue, and then this is the soft palate of the tongue. So posterior one-third of the tongue goes here, which is in contact with your oropharynx, okay? Now, the genohyoid bone and the hyoid bone and the mandible bones are really important to know because most of the muscles connect from here. We're also going to cover this, so don't worry. Okay, moving on, we have the hard palate here, which you can see in the cross-section here. It looks something like this. This is the soft palate, and then here is where the uvula would usually be, but you cannot see it in the model here. We also have the floor. This is the tongue. These are your teeth, okay? And yeah. Coming on to this picture, very, very important. Learn it like your name. This is so important to know. So here, X is basically the frenulum, which is, it's found at the base of your, it's found at the floor of your tongue, which connects the tongue to the floor of your mouth, okay? So frenulum is a really frequently asked question in the OSPE as well. So need to know this, okay? And these right here, these small, wait, hold on. Let me just zoom in. Okay. So these that you see here, these are small little holes that are for the glands of the mouth, okay? So these are the openings of the mandibular glands. Specifically, they're openings of sublingual glands where the submandibular ducts usually drain, okay? That's what it is. And Y is basically the sublingual cranicle. This right here, this bulgy thing that you see, this entire bulge that you see is a sublingual cranicle. So these are the sublingual gland holes where the submandibular duct drains. This is the frenulum, and this is your sublingual cranicle, this entire bulge thing. Okay, this picture has it all labeled. So this is the sublingual cranicle, this is the frenulum, and this is also the sublingual fold. Not that important, but for your knowledge, you should know it. Okay, here. So what is the vestibule? Vestibule is basically kind of like a small cavity or like a small entrance in the body. So you see this part is basically called the vestibule. So this part is just showing you that this is the vestibule here, okay? So don't get that confused. X is the papilla of the parotid gland, also really important labeling. And Y is just, it shows that the vestibule is near the second upper molar, which is your molar teeth. That's pretty much it. Know the papilla of the parotid gland here. Okay, now coming to the tongue, which is a very, very important part. Is everything clear in the oral cavity? Okay, I guess. Okay, thank you. Okay, so for the tongue, we know it's the sac of the mucous membrane, which is filled with skeleton muscles that's located in the oral cavity. Tongue is a really important thing to know because there's inverted V, which is the sulcus terminalis right here, and the depression at the tip of the sulcus terminalis is called the foramen cecum. So this entire V thing is sulcus terminalis, and this is the foramen cecum, the apex, you could say. Okay, we have these rounded things here. They're called circumvallate papillae, and they're basically taste buds. They're the names of taste buds, okay? And as we said, the posterior one-third of the tongue lies in the oropharynx, and these are your palatine tonsils, right? Posterior one-third of the tongue is also in line with the other tonsils, which are called lingual. So these tonsils are lingual tonsils, and these tonsils are palatine tonsils, okay? Okay. These are just more labelings for better understanding. This is a really good picture that I found online. This is the palatine tonsils. These are your lingual tonsils. This is all posterior one-third of the tongue. This is anterior two-thirds of the tongue, okay? These are all the papillae that we're going to talk about. So the circumvallate papillae lines the circus terminalis, and this is the foramen cecum, okay? These papillae, we're going to cover them, so don't worry, I'm not going to cover them here because they're going to confuse you a little bit. This is something that I labeled when I was doing GI, and it's really helpful. So this is basically the foramen cecum, which is the apex, and then this is the you see these little circles. These are circumvallate papillae, and then this is the root of the tongue, which is also the lingual tonsils. And here, right here, is the palatine tonsils. This is usually the model they use in the exam. So, the more you know, the better. Okay, so for the innervation of the tongue, really important. So anterior two-thirds of the tongue is innervated by different cranial nerves, whereas the posterior one-third of the tongue is innervated by different cranial nerves. Posterior one-third of the tongue, the general and the special sensations are innervated by the same nerve, cranial nerve, which is glossopharyngeal nerve, okay? So posterior one-third is easy to remember, just glossopharyngeal, which is ninth cranial nerve. Anterior two-third is a bit tricky, and the way I learned it is that anterior two-thirds, special sensations such as taste, okay, is usually supplied by the facial nerve. And how I learned this is when you eat something nice, your expression just changes, So your facial expression changes. That's how I learned it, facial nerve. So for taste, so special sensations, okay? So cranial nerve 7 is for special sensations of anterior two-thirds of the tongue. If someone asks you posterior two-thirds or posterior one-third of the tongue, special sensations is glossopharyngeal. It does not change, okay? Anterior two-thirds general sensations is usually trigeminal nerve, okay? So anterior two-thirds, if you divide it, the general sensation is usually trigeminal, which is the fifth cranial nerve. And if you take the taste, which is the special sensations, it's usually the facial nerve, which is your seventh cranial nerve. Okay, there. Okay. This is just a basic overview of what we just discussed. Mandibular nerve is basically the part of trigeminal nerve. So trigeminal nerve is divided into three. There's ophthalmic, maxillary, mandibular. Mandibular is the part of the trigeminal which supplies the general sensation in the tongue. You can write trigeminal, you can write mandibular. Both of them are correct. I would suggest just write trigeminal. Don't go into much details. Okay, so facial nerve is for the special sensations. For the anterior two-thirds of the tongue, posterior one-third of the tongue is supplied by the glossopharyngeal for general as well as special sensations. Base of the tongue is supplied by vagus, both general and special sensations. Okay, so the only difference is anterior two-thirds of the tongue. Okay. Coming to the muscles of the tongue, so there's extrinsic muscles and there's intrinsic muscles. And one of our first slides, we said both extrinsic and intrinsic muscles are supplied by the hypoglossal nerve, right? So extrinsic muscles are basically muscles that originate from outside, but then they come and attach to the tongue. So they're originating from somewhere outside the oral cavity, not outside, but like from like a bone, and then they're coming and attaching to the tongue, okay? So we have four extrinsic muscles here. We have hyoglossus, genioglossus, styloglossus, and then platoglossus. Okay? So for the origin of these muscles, it's really easy to remember because it's in the name. So hyoglossus is from the hyoid bone to the tongue, okay? So glossus means tongue, and hyo is just an abbreviation for the hyoid bone. So if you look at this, can zoom in 1 second. Yeah. You see this is the hyoid bone, and this is the hyoglossus muscle. So it's going from the hyoid bone to the tongue, there, okay? So that's the hyoglossus, that's the first extrinsic muscle. Then we have genioglossus, super important. Genioglossus starts from the, wait 1 second. Genioglossus starts from the genohyoid bone. From the genoid tubercle, not the genohyoid bone. Genoid tubercle to the tongue. So this is your genoid tubercle, and this is genioglossus. So it's going to the tongue, so genioglossus. Okay, and then the main muscles for the protrusion of the tongue that basically protrude your tongue out are styloglossus and platoglossus. Styloglossus is from the styloid process of your skull to the tongue. So this is styloglossus. Okay, and then you have platoglossus. Platoglossus is this one. So it's going to the soft palate of your tongue. Okay, so this one here. So those are your four extrinsic muscles, and they're all supplied by hypoglossal nerve except one, which is palatoglossus, mostly because it's going to the palate, so it's above the tongue, not below it, whereas all the other muscles are usually they're coming and attaching to the tongue from below it, right? So that is why it's supplied by other nerves. whereas all of these three are supplied by hypoglossal nerve. Okay, genioglossus is super important to remember. Okay, for the hypoglossal nerve, now we said, okay, extrinsic muscles as well as intrinsic muscles are supplied by hypoglossal nerve. So if hypoglossal nerve is damaged, these muscles are not going to work. So your tongue is going to have, like, your tongue is not going to be able to protrude out. So what happens is if the right hypoglossal nerve gets damaged, your tongue, when you protrude it out, it's going to go to the right side, okay? But if the left hypoglossal nerve is damaged, it's going to go to the left side. So the tongue usually protrudes to the side of the lesion, okay? So if it's right hypoglossal nerve, it's going to go to the right side. If it's left, it's going to go to the left side, okay? That's really easy to remember because it's ipsilateral sides, okay? And if both the right and left hypoglossal nerve gets damaged together, your tongue is just not going to protrude out. It's just going to stay in, like, the person can't talk because none of the muscles of the tongue are working. Neither left, not right. Okay. For the intrinsic muscles of the tongue now, these are the muscles that originate in the tongue and end in the tongue. So they're not coming from any bone like extrinsic muscles, right? The three muscles that we're going to talk about are superior longitudinal, inferior longitudinal, vertical, and transverse muscles. So if you look here, this is your superior longitudinal muscle, okay? And then you have your vertical and transverse. So basically this is all vertical and transverse. And then inferior longitudinal. So these three, okay, here are intrinsic, okay? And these four here are extrinsic. You can just see a part of the extrinsic muscles, mostly because they all connect to the bone, as we saw in the other picture. Okay, so these are the extrinsic and the intrinsic muscles that you need to know. For the lymphatic drainage of the tongue, really important, submental and submandibular nodes, they all drain into the deep cervical lymph nodes. I'm going to show it in the picture here. It's much better. So you can see this is the submental nodes, okay, and this is the submandibular nodes, and they all drain into the deep cervical nodes right here. So you can see the connection of the deep cervical nodes here. So really important to remember, submental, submandibular, deep cervical nodes. Okay. For the histo of the tongue, okay, so we know that there's papillae, right? Now, what are lingual papillae? These are basically mucosal projections made of connective tissue covered by the stratified squamous epithelium. Now, mostly, these papillae are only located on the anterior two-thirds of the tongue. So you're not going to see them in the posterior one-third of the tongue. And we have 4 different types of papillae, which we're going to get into. So starting off with the filiform papillae, filiform is the smallest and the most numerous, and they also increase friction. And a very important point is they don't have taste buds. Filiform papillae do not have taste buds. So filiform papillae are these little dots that you see, these dots that you see here. These are all filiform. So they're small, they're very small, and they're numerous, and they don't have taste buds. Their only function is to increase friction of the food, to make it easier for you to gulp down the food, okay? And they also have keratinized tips. Now, if you look at them on the histo slide, this is what they look like. So you have, sorry, so you have these are the filiform papillae that you see here. These are keratinized. So if they're keratinized, wait, my pen, okay, sorry. So if they're keratinized, you know that they're a light pink color, right? So this is the epithelium of the tongue, which is stratified squamous. And the filiform papillae is above the epithelium because it's keratinized, okay? That's pretty much it. For the fungiform papillae, these are larger and these are larger than the filiform and they're mushroom shaped. So the easiest way you can remember them is fungiform, so fungi, and fungi is a mushroom. So they look like a fungi. So that's pretty much it. They're mushroom shaped, right? Okay. So they also, the most important point here is they have taste buds. Okay. And they're also scattered along the filiform papillae. If you can see here, these are fungiform papillae all over. These white things here, these are fungiform. And they have taste buds. So fungiform has taste buds. Filiform does not have taste buds. Don't get them confused. And for the histocytes, you can just see that this looks like a mushroom, and then it has, like, you can say 5 different lobules inside it, okay? don't get this confused with the circumvallate, which we're going to come to now. Circumvallate also has taste buds. So fungiform and circumvallate papillae both have taste buds. Filiform does not have taste buds, okay? These circumvallate, we know where they're found, right? We talked about the sulcus terminalis. We said there's the foramen cecum, and this is where they're found. They're found in the V-shaped arrangement in front of the sulcus terminalis, right here, okay? So they're large and dome-shaped. And this is what circumvallate looks like. So don't get this confused with fungiform, because fungiform, you can see circumvallate has kind of like 2 lobes, whereas fungiform usually like has kind of 5 lobes. That's how I used to differentiate between them. So circumvallate has Ibner glands. So this is one of the very high differentiating points that you can use in your OSPE if they ask you to differentiate between the 2 glands, that this has an Ibner's gland, which is serous. So serous glands are basically the glands that release watery secretion, okay? So these that you see here, these purple things, right? These are your serous glands, and these are in the circumvallate papillae, whereas they're not in the fungiform papillae. Okay, so circumvallate, fungiform, taste buds, filiform, no taste buds. Coming to the foliate papillae is not found in the humans. It's a very important point. It's only found in animals. These are not found in the humans, okay? Foliate papillae are the parallel ridges that you see on the tongue here. This is basically what foliate papillae is. And coming down to the picture, they also have taste buds, and they're spindle shaped. So their taste buds are very unique. You can tell that this is a taste bud because it's spindle shaped, okay? Yeah. That's pretty much it for the foliate papillae. Oh, okay, and the tongue. So does anybody have any question for the tongue? Okay, I guess not. We're gonna move on. Okay, so we're gonna start with the glands. We have 3 salivary glands that we're gonna talk about. We have the sublingual, submandibular, as well as the parotid gland, okay? So this is the sublingual, it's right below your tongue. You have the submandibular, it's around the mandible bone, and then you have the parotid gland. Okay, we're gonna start with the parotid gland. So every salivary gland that we're going to talk about, not every, but most of them are covered by a fibrous capsule, okay? So there's going to be a fibrous capsule that's going to be covering the parotid gland, and the septa of this capsule is going to divide the gland into lobes. So if you see here, this is the capsule, and these are the lobes, and this is the septa this is the septa that's dividing your gland into lobes, into different lobes. So this is the capsule, and this is the septa here that's dividing it into lobes, okay? One important thing about glands is that they're gonna have ducts. So as soon as you look inside, look more deeper into the glands, you're gonna see the ducts here. And the ducts are usually either simple cuboidal or simple columnar. And if you see these ducts, they're called intralobular ducts. In the salivary glands, they're called intralobular ducts, okay? Okay, for the parotid glands, it's also going to have a serous acini. So you see this is your serous acini. These are your pyramidal cells. The cells inside here are your pyramidal cells. This is the lumen. So the pyramidal cells are surrounding the lumen. So this entire thing is your serous acini. Now what a serous acini does is it's also going to release the serous. So serous is basically watery secretion, as we said. So this is going to help in releasing watery secretion through the parotid gland. Okay, now these are also lined by myoepithelial cells, and this is a nuclei. So myoepithelial cells, sorry, not that. Myoepithelial cells are these, the flattened ones, and these are the nuclei. And these are the pyramidal cells inside. Okay, so this is a serous acini. So parotid gland are mostly serous glands. Okay, they release watery secretion. We talked about the myoepithelial cells. These are the myoepithelial cells, and there's connective tissue all around for supporting structure. Okay, going into the submandibular, we know that the submandibular is also surrounded by the fibrous capsule, and the septa also divides it into different lobules right here. So you're going to see the septa dividing it into different lobes. Okay, now submandibular is a mixture of serous as well as mucus acini. So you're going to find mucus secretions as well as serous secretions or watery secretions from the submandibular gland. So when you look at the histology slide for the submandibular gland, you're going to find 3 different types of structures. First one is going to be the mucus acini, which is going to appear pink, okay, which is going to release mucus. And then you're going to find let me find a serous acini. So this is going to be the serous acini. The purple is going to be the serous acini. Pink one is going to be the mucus acini. Okay. You're also going to find the serous demilunes. Serous demilunes are a major giveaway that this is a submandibular gland. Now, what is a serous demilunes? It's basically a crescent-shaped serous cells. Wait, let me find one. This right here. You can see this. This is kind of like a crescent-shaped serous cells, and they're usually in close contact with mucus acini. So wherever you see mucus acini, this is one mucus acini. This right here would be the serous demilunes, which is crescent shaped. See this mucus acini? This is going to be the serous demilunes. Okay, so these are the three structures you're going to see in the submandibular gland: the mucus acini, the serous acini, and the serous demilunes. Usually they're a mix, but most of the time, if you compare between if they secrete mucus more or serous more, they secrete serous more, okay? And that's it for submandibular. They also have the duct system, which is interlobular duct. Let me find one here. You can see this. This is a duct. So a duct is usually either simple columnar or simple cuboidal, mostly because you're gonna absorb stuff there and stuff like that. Okay, here. Oh, also functional integration. We talked about mixed serous and mucus secretions travel through the duct system. Okay, now sublingual is our last gland for the tongue or for the oral cavity in general. So sublingual is going to be more specific to mucus secretions, okay? So submandibular is a mix, sublingual is going to be mucus, and what else do we have? Parotid is going to be serous, okay? So organization of sublingual is they do not have a fibrous capsule. Whereas sublingual, submandibular and parotid, they had fibrous capsule. Sublingual does not have a fibrous capsule. Instead of a fibrous capsule, it just has loose connective tissue that's around, and that's what's going to divide the gland into different lobules as well. So as we said, that it's going to be mostly mucus secretions from this gland. So you're just going to see mucus acini, which is going to be pink. And you're also going to see the ducts, which is interlobular ducts here, just ducts. So in the histology slide, if you just see serous acini with the duct, it's going to be parotid gland. If you see serous acini, mucus acini, and you see serous demilunes, it's the submandibular. If you just look at mucus acini, it's sublingual. Okay, that's how you're going to differentiate between them. So we talked about the ducts as well. This is just a distinction between all three of them. So parotid is only going to be serous. It's going to have a fibrous capsule. Your sublingual doesn't have a fibrous capsule. Very important to remember. Instead, it has a loose connective tissue. Okay, it doesn't really have serous demilunes. You can't really see serous demilunes on the histology side, but it does have a few of them. Okay, submandibular is where you're going to see the serous demilunes in close contact with the mucus acini and the serous acini. Okay, and yeah, that's pretty much it. Okay. Does anybody have any questions? Because I'm going to be putting some practice questions now. If you guys have any questions, please feel free to ask because we really want to help you guys with this. Oh, wait. If you guys don't have questions, we can do the practice ones. Okay, guess not. I am going to start the practice questions. If anybody does have question, we're going to address it. Don't worry. Okay, so what is most of the SNI in the submandibular gland composed of? Is the mucus, serous? Yes, it is the serous. Good job. Okay. Next question. Label A, B, and C. Might be a bit tricky, but you guys got this. Mm-hmm. What's A? You guys remember the gland openings that we talked about? Can you tell me what glands we talked about? Yes, yes, yes. A is sublingual glands. What is C? You guys remember the bulge? Okay, so these, A is your submandibular ducts, B is the frenulum, and C is the sublingual folds. Oh, sorry, I thought this was this, but it's actually this. If the pointer was pointing at this, it would be the sublingual cornicle, which is the bulge, but it's pointing at this, which is the sublingual folds, okay? This is your frenule, and then these are your submandibular ducts, or also sublingual gland opening. Oh, okay. Another question, guys. What kind of papillae is shown in the picture on the right? Okay, where in the tongue are these located? Is it anterior or posterior? Okay, I saw an answer. Okay. And name two structures that are present in this type of papillae. Do they have taste buds? Do they not have taste buds? Nice. Nice. Okay. Someone said Ebner's gland. That's a really good answer. Okay. So these are circumambulate papillae. I saw someone say fungiform. These are not fungiform. Remember, fungiform has like it kind of looks like that for fungiform. These are circumambulate, okay? And then they're located anterior to the sulcus terminalis. And they also have Ebner's glands as well as taste buds. So these are your Ebner's glands here, right here. And they have taste buds as well. Okay. Name the structure. Name the structure, this. Just talked about it. And name the function of the structure at point B. It is function of the structure. Okay. Okay. What about B? Nice. Good job. Good job. So B is basically the taste buds, and these are Ebner's glands or Sears glands. Okay. Supposed to be question 5. Sorry about that. Now name the muscle pointed at by the arrow. So this muscle. Look at what bone it's going to and name it. Yeah, it's okay. That's the bone. That's not the name. Okay, hypoglossal nerve is right. Genioglossus, yes. It's genioglossus. Also, it's not geniohyoid bone. It's the genoid tubercle. Wait, let me just show it to you guys again. Okay, scrolling all the way up. It's supposed to be, yeah, there we go. Okay, so this is the genoid tubercle. This is the genohyoid. So it doesn't exactly join to this. It actually comes and the fibers join to this. So this is the genoid tubercle. Where's the hyoglossus muscle? Oh, wait, 1 second. So this is the hyoglossus muscle. You see this? This. The hyoid, from the hyoid bone. Do you mean on the model? Let me see. You can't really see it here. Yeah, it's not really visible here. This is a genioglossus. In the summary table, wait 1 second, let me see. It said the mandibular has mostly mucus SNI. Which one? The distinction? Oh, this one. Oh. Okay, I'm gonna address this, don't worry. I'm gonna address this by the end of this session if it's mostly mucus or serous. Because this is from internal resources. So I'm gonna address it, don't worry. I'll find the answer to it and I'll let you know if it's mostly serous or mostly mucus. Okay? Oh, sorry, my bad. Okay. Any other questions? Yeah. If you don't have any other question, we can start with the pharynx and larynx. Okay. I think that's no questions. Let's start with the pharynx and larynx. Okay, so the pharynx comes first, which is then followed by the larynx in the respiratory and the digestive pathways. Okay, so the pharynx is just a muscular tube that connects your nasal as well as oral cavities to the larynx as well as the esophagus. Okay, and the larynx, which is the voice box, is located below the pharynx and it serves as a passageway for air into the trachea. Okay, also producing your voice production. Okay. For the pharynx muscles, they're also super important to know. We're going to talk about 6 major muscles. There's going to be 3 constrictor muscles and 3 strap muscles, where right and left both meet in the midline. So these muscles are going to come from the right and then they're going to come from the left and they're going to meet in the midline. Okay. So just this one part of one side of the muscles you're seeing. But there's going to be left side as well, and they're just going to meet in the midline. So the 3 pairs of constrictor muscles that we're going to be talking about are going to be your superior constrictor, your middle constrictor, and then your inferior constrictor. Okay, and the 3 pairs of strap muscles, which we're going to talk about them here because they're not labeled there, are your stylopharyngeus, platopharyngeus, and salpingopharyngeus. Okay, now coming from the tongue, this is the same. So the origin of the muscle is at like the starting of the name of the muscle, and then pharyngeus just means pharynx. Okay, so they're coming and they're attaching to the pharynx from this origin. So stylo means styloid process. Okay, so stylopharyngeus is a different muscle and styloglossus is a different muscle. Okay, so don't get them confused. So this is your styloid process. So this is where your stylopharyngeus is going to come from, and then it's going to attach to the pharynx. Okay, your palatopharyngeus is going to be from the soft palate of the tongue. Okay, so this is going to be your plato. Wait, hold on. This is going to be your platopharyngeus. This is your palate. Okay, there. And then salping basically means a tube. Okay, so salpingopharyngeus is just gonna go and attach. It's gonna come from a tube basically, and it originates from a tube, and then it goes and attaches to the pharynx. Okay, yeah, that's pretty much it for the pharynx. So pharynx has 4 different parts that we're going to be talking about. Actually, sorry, 3 different parts that we're going to be talking about. So this is your hard palate, this is your soft palate, and this is your tongue, right? Now this is going to be your pharynx. This entire thing is going to be your pharynx, which is going to continue into the esophagus. So it has 3 parts. So nasopharynx is behind the nasal cavity, okay? Oropharynx is behind the oral cavity, and laryngopharynx is behind the larynx. So this is the larynx. This is the epiglottis, right here. Wait. This is the epiglottis right here. And this is the larynx, okay? The epiglottis is open right now. Okay, so we just talked about this. The larynx that passes behind the nasal cavity is called nasopharynx. So we also have a eustachian and auditory tube right here. This is your eustachian and auditory tube. Now this is we're going to be covering the rest of the tonsils that we didn't do. So edges of the tube here. Okay, edges of the tube here are raised. These are called your tubal tonsils, okay? And this here is your pharyngeal tonsils. So if these are inflamed or if there's any problem with these tonsils, the pharyngeal tonsils, it's called tonsillitis, okay? So this is what we call tonsillitis. So this is your pharyngeal tonsil and this is your tubal tonsils. And then we talked about these ones. We said palatine tonsils, which were lateral to the oral cavity, remember? And then these are your lingual tonsils. So these are the 4 tonsils that we're going to be covering in the GI block. Okay. We talked about this. We said oropharynx, laryngopharynx, and it continues to the esophagus. Okay. Now, this is also called Wildeyer's ring or pharyngeal ring, okay, where we talk about all the 4 tonsils. So we said that this is pharyngeal tonsil, which is in the nasopharynx, right? And then we have the tubular tonsils, which is the ridges of the eustachian or the auditory tube, okay? And then you have the palatine tonsils, which are lateral to your oral cavity. And then you have the lingual tonsils, which are below your tongue. So they make a ring like this, which is called Wildeyer's ring. This is just a better picture to orient yourself. So this is pharyngeal tonsils, and they look something like this here. Okay, these are palatine tonsils. We talked about this. This is a tubal tonsil, which is kind of like the ridges raised off the auditory or eustachian tube. And then this is your lingual tonsil right here. It's like behind the tongue, posterior to 1/3 of the tongue. Okay, everything clear, guys? Okay, gonna talk about the esophagus, sorry. Now, esophagus, if there's an enlargement of the left atrium, it could constrict the esophagus. Really important point to remember. The three main branches coming from the abdominal artery is the celiac trunk, the superior mesenteric, and the inferior mesenteric. Celiac trunk supplies your foregut, superior mesenteric supplies your midgut, and then inferior mesenteric supplies your hindgut. Now, the blood supply of the esophagus there's three different regions of the esophagus. It's divided into three different regions. So there's going to be cervical region, thoracic region, and then the abdominal region. So the cervical region is supplied by your inferior thyroid arteries, okay, which is here. These are your inferior thyroid arteries. These are going to supply the cervical esophagus. And then the thoracic esophagus is going to be supplied by the esophageal branches of the aorta. So this is the esophagus right here. And these are the branches, esophageal branches of the aorta that's going to supply the thoracic region of the esophagus, okay? Then we have the abdominal region of the esophagus, which is supplied by the left gastric artery. And this is going to make more sense after we talk about the blood supply of the stomach. So this is the left gastric artery, and that's going to supply the end or the abdominal region of the esophagus, which meets the stomach, okay? That's the blood supply. For the venous drainage of the esophagus, it's kind of similar to the blood supply of the esophagus. So cervical region is drained by the inferior thyroid veins, and cervical region was also supplied by the inferior thyroid artery, okay? And then the only difference here is the thoracic region, which is drained by azygous as well as hemiazygous veins. So if you look at the picture here, this is, one second. If you look at the picture here, this is your hemiazygous and this is your azygous. So these are drained by hemiazygous and the azygous veins. And then your abdominal region is drained by the left gastric vein and the inferior phrenic vein. So it's supplied by the left gastric artery and it's drained by the left gastric vein and inferior phrenic vein. So the only difference here is the thoracic region and that there's an inferior phrenic vein in the abdominal region. The lymph drainage, however, for the cervical region, it's in the deep cervical nodes, which makes sense because the cervical region, the lymph nodes of the cervical region are all cervical nodes, right? So deep cervical nodes. What else ranges into deep cervical nodes? We talked about two more lymph nodes of the tongue, remember? It was submandibular and if anyone remembers. Submental, good job, thank you. Okay, so cervical region is drained by the deep cervical nodes. Thoracic region is drained by the superior and posterior mediastinal nodes. It's going to make more sense if you after you take the anterior abdominal wall. Abdominal region is going to be supplied by the celiac nodes. Important. Abdominal region, everything, celiac nodes. Stomach, celiac nodes. Esophagus, celiac nodes, okay? Cervical region, deep cervical nodes. Okay, is that clear? Does anyone want me to repeat the blood supply, the veins, and the nodes? So alcasia is basically a failure of the esophageal sphincter to relax. So the lower esophageal sphincter. So when you swallow food, right, your esophagus is gonna contract, relax, just for the peristalsis of the food to go down to the stomach. However, if your lower esophageal sphincter is not relaxing and it's always contracted, you're not gonna be able to protrude the food down to your stomach. So there's a test called the barium swallow, where the patient basically swallows a barium dye and the doctor basically observes the constriction of the esophagus to diagnose echolalia, which is basically when the lower esophageal sphincter is not working. And this is what it looks like. Okay. Coming to the histology, also these boxes on the slides, I basically looked at the important points of your OSPE that came out, and the boxes on the slides just basically tell you that it was emphasized in the important points that you guys got. Okay, so esophagus has obviously four different types of layers. Well, we talked about a mucosa, submucosa, muscularis externa, adventitia. Okay, so mucosa, we have the stratified squamous epithelium. Very important to remember the epithelium of the esophagus. It's stratified squamous. Okay, then it's lined by the lamina propria, muscularis mucosa, and let me show it to you guys here. So this is the epithelium, stratified squamous epithelium for the esophagus, then lamina propria, and then muscularis mucosa. Okay, And then we have the submucosa, where we have irregular dense connective tissue, and also the glands are present in this layer. Okay, so this is your submucosa layer. Basically, you can see the glands here. So this is the submucosa layer. Okay, for the muscularis externa, you have inner circular and outer longitudinal layers. But because of the cross section and histology being like in a transverse section, they both look the opposite. So the circular muscle fibers are going to look longitudinal and the longitudinal are going to look circular. So don't get it confused, okay? So the third one is muscularis externa. So this, because it looks longitudinal, it's going to be inner circular. And this, because it looks circular, is going to be outer longitudinal. Does that make sense? Or you can just remember anything that's to the inside is inner circular and anything towards the outside is the outer longitudinal. That's an easy way to remember it too. So because this is towards the outside and it's closer to the adventitia, right? It's going to be the outer longitudinal. And because this is away from the adventitia, it's going to be inner circular. Okay? And then we have the adventitia, which is the fourth layer, which is the dense connective tissue. Okay? And you can also call it serosa, but that's only in the abdominal esophagus. Because in the abdominal esophagus, the epithelium changes mostly because it's gonna go and like the epithelium is gonna have like a distinction from the esophagus to the stomach, which you're gonna see. Okay, now constrictions of the esophagus, there are four different levels where the esophagus can be constricted. So we have the pharyngoesophageal constriction, which is at the C6 level. Then you have the aortic constriction, which is at T4, left bronchial constriction, which is at T6, and diaphragmatic is at T10. Okay, so just memorization. For the constrictions of the esophagus, this is Dr. Atif's slide pictures. Basically, this is indentation due to the arch of aorta. So if there's esophageal constriction at the arch of aorta, this is what's going to look like. And the constriction level is going to be T4. Yep, right there. Okay, and then if it's indentation due to the left main bronchus, the left bronchial constriction is going to be because of the level T6. So arch of aorta is T4, and then T6 is left bronchial constriction. Okay, T10 is basically going to be the diaphragmatic constriction. Okay, this is what I was talking about. Esophagogastric junction is where the esophagus meets the stomach. Okay, so this is going to be a clear distinction between the esophagus and the stomach that, oh, this is where the esophagus ends and this is where the stomach starts. Because the main pointers that you're going to see in the histo slides are that the stomach has rogae, which we're going to talk about in the stomach organ, but it has rogae. Like rogae is basically these indentations in the stomach which increase the surface area. Okay. Whereas in esophagus doesn't have rogae, it's just like stratified squamous epithelium. So esophagus has stratified squamous epithelium, which immediately changes to simple columnar. So there's no, there's no like slow change. It's just like abrupt. Okay. So this right here is stratified squamous, and then if you look at the epithelium here, this is all going to be simple columnar in the stomach because you need to absorb your food, you need to take the vitamins and the minerals and everything. Okay. So also, because we're in the distal esophagus, so there's going to be increased thickness of the muscularis externa compared to the proximal esophagus. So if you look here, the muscularis externa thickness is going to be thickened mostly because peristalsis of the food going to the stomach, so more work at the lower esophagus. Okay? Any questions? They're going to be practice questions for the pharynx and larynx and your esophagus now. So if you have any questions before we start the practice questions, please ask. Okay, let's go then. Okay. Question number 1. What is the structure/organ that can be inferred from the histological image? And what type of epithelium lines the mucosa? And also, what is the primary function of the mucosa? Esophagus, right? Good job. What type of epithelium? Stratified squamous. Good job. Good job. Good job. Okay. And what is the one primary function of the mucosa in this organ? Like, why is there mucosa in this organ? peristalsis. Good job. It's also for peristalsis, and it's also for your esophagus to be protected from like hard or fibrous type of foods. Okay, question 2. What are the external constrictors and what are the internal layers? Internal layers is basically the strap muscles that we talked about because they go towards the interior. One second, I can't see the question. Yes, it is by the muscularis it's by the muscularis external layer. As you're going down to the lower esophageal esophagus, basically, the muscularis externa basically thickens. Okay? And so here it's just talking about what is the primary function of the mucosa? So you can say, okay, it helps in the peristalsis because mucus secretions also help in the peristalsis of the food to go down better and smoother. And they also protect the esophagus from harsh or abrasive foods. You know, when you eat something hard or like you eat a seed. Does that make more sense? Okay. Superior, inferior, and middle. Nice. For the internal layers or the muscles that we talked about, there's going to be your platopharyngeus, your stylopharyngeus, and your salpingopharyngeus. Okay? Can you start with the stomach? Okay. I'm going to be starting with the stomach now. So after the abdominal esophagus has gone down, it's going to basically connect to the stomach, okay? And it becomes cardia. So this part of the esophagus, it's not esophagus anymore, it's called cardia, and it basically makes the stomach. So the upper part is called fundus, okay? And the lower part is basically called pylorus, okay? So this entire thing is going to be where your pyloric canal, pyloric sphincter, everything just comes in, and it's going to continue as the small intestine, which is the duodenum, okay? This is the body of the stomach. So this is the lesser curvature, and this is the greater curvature. So the greater curve is the greater curvature, and the lesser curve is the lesser curvature. Okay, so this is basically what the slide says. And folds within the stomach are called rugae, which are more visible on the histo slide, or if you look at the stomach from inside. Okay. Now for the stomach blood supply, super duper important. So we're gonna be talking about this. And we're going to take it slow because it can be a bit confusing. So the blood supply of the stomach starts from the celiac trunk, okay? And it's going to divide into 3 branches. So there's going to be the splenic artery, the left gastric artery, and the common hepatic artery, okay? So left gastric artery itself, just leave it. It's not going to divide into anything, okay? Left gastric artery is just going to go and supply the lesser curvature, okay? So left gastric artery, lesser curvature. Okay, now we're just going to focus on the splenic and the common hepatic. Okay, we're going to start with the splenic artery. The splenic artery is going to go behind the stomach to go and supply the spleen. Okay, so it's going to give branches to the spleen because it's the splenic artery, right? And then it's also going to give us short gastric arteries, which are going to supply the fundus of the stomach. So this part of the stomach, short gastric arteries. Okay, and it's gonna splenic artery is basically gonna give us that, and it's also gonna give us left gastroepiploic. So left gastroepiploic is gonna supply the greater curvature. So left part of the greater curvature is gonna be supplied by left gastroepiploic. Right part is gonna be by the right gastroepiploic. Okay. So the basically 2 major arteries they're gonna receive from the splenic artery is gonna be the short gastric artery and the left gastroepiploic artery. Okay. And then you also have the left gastric artery, which is obviously, as we said, goes and supplies to the lesser curvature. Talking about the common hepatic artery, common hepatic from the name, it's for the liver. Okay, but it further divides into hepatic artery proper and gastroduodenal artery. Okay, gastroduodenal is what we need. For the hepatic artery proper, there's going to be three major divisions as well. There's going to be right hepatic artery, left hepatic artery, which is going to go to the liver. Okay, and it's going to give us the right gastric artery. So we already got the left gastric artery, and now we have the right gastric artery. So these are both going to supply the lesser curvature of the stomach. Okay, sorry, that's three S's. Lesser curvature of the stomach. Got it? And then you're going to have the gastroduodenal artery, which is the second branch of the common hepatic artery. What does the gastroduodenal artery do? It's going to give you pancreatic duodenal, which is going to be for the duodenum and the pancreas. Okay, and it's going to give us right gastric epiploic artery. So left gastroepiploic was from splenic, right gastroepiploic is from gastroduodenal from the common hepatic. Okay, so right gastroepiploic is going to supply the greater curvature from the right side. Left gastroepiploic is going to supply the greater curvature from the left side. Okay, a lot of information to take in, but inshallah, as we're going to go, you guys are going to have it all in your mind. So we have the three major branches from the celiac trunk. As we said, there's a mnemonic that's commonly used. It's called left hand side. So L stands for left gastric artery that we're going to receive from the celiac trunk. H from the hand stands for common hepatic artery that we're going to receive from the celiac trunk. And S is for the splenic artery. Okay, super important point. Super important, guys. Super important. Splenic artery always comes. Always comes. It's a very beloved question of the professors. Okay, so you can see here, splenic arteries goes behind the stomach. So if you want to see the splenic artery, you'll have to flip over the stomach to look at it, because it's going to go from behind the stomach, supply the spleen, give our two major branches, which are going to be short gastric artery, it's going to supply the fundus, and then it's going to give you the left gastroepiploic, which is going to supply the greater curvature. Okay, then you're going to have the common hepatic artery, from the celiac trunk. It's going to give you your hepatic proper, which is going to give you your right gastric. It's going to come here. And then it's also going to give you your gastroduodenal. Gastroduodenal goes down, gives you your right gastroepiploic. Is that clear? This is just a really good picture that I found, and I thought it was really useful as well, because splenic artery goes behind, supplies the spleen, short gastric, fundus, all of that again. This is just what what I just explained, just in text if you guys want to read it. Also, left gastric artery supplies to the abdominal esophagus. If you guys remember, we talked about the blood supply, and we said, okay, cervical regions by inferior thyroid arteries, and then abdominal regions by left gastric, and then we had one more region. Can someone tell me? Cervical, thoracic. Can someone tell me what thoracic was supplied by? It was from something from aorta. Yes, good job. Esophageal branches from the aorta. Yes, yes, good job, guys. Really, really good job. Okay, this is basically how you're going to find these branches of the celiac artery in cadaver. Now, basically, when you look at this is going to look like a Mercedes sign. I don't know which professor said that, but this basically looks like a Mercedes sign because it's kind of like an M. Okay, so you're going to see the splenic, you're going to see the gastric, and you're going to see the common hepatic. So which gastric is this, left or right, from the celiac trunk? Left, good. Okay, and then you're going to see the splenic, which is going to give you two branches. Hepatic is going to give you two branches, which are further going to divide and give us what we need. Oh, lymphatic drainage, very important. Everything in the stomach goes to the celiac nodes. Okay, everything. Gastroepiploic, left gastric, everything, every vein, everything goes to your celiac nodes. That's all you need to know. Okay. The portosystemic anastomosis is where the left gastric vein and the right gastric veins are basically part of the portal system. Okay, this is esophagus, and then this is the liver. Okay, so the left gastric, right gastric are part of the portal system, and the esophageal part is basically where the systemic and the portal systems meet. So if there's an injury to the liver, there's going to be portal hypertension. okay, which is basically going to cause the portal vein engorgement, and there might be esophageal varicose. These are basically just some lab pictures to show right gastroepiploic artery. You have the pyloric sphincter, and there's the constriction. Can someone tell me where right gastroepiploic artery comes from? Which branch? Which branch of common hepatic? Gastroduodenal. Good job. Okay. For the stomach histology, super important to remember that the glands here are not in the submucosa. The glands in the esophagus were in the submucosa. The glands in the stomach are in the mucosa. Okay? So we have simple columnar epithelium here. Okay, we talked about stratified squamous epithelium of the esophagus turning into simple columnar epithelium for the stomach, right? We talked about rogae. This thing, these little projections are rogae. They increase surface area for the absorption in the stomach. Okay? Now we're going to have these gastric pits that you see here. So basically rogae, as they're going, they basically make these gastric pits. Okay? And into these gastric pits is where the gastric glands open. And all the gastric glands are usually in the mucosa, they're not in the submucosa. That's the only exception we have, which is in the case of stomach. Okay? Submucosa, there's going to be no glands. No glands here. They're going to be in the mucosa. Okay? There's going to be, you can see, this is going to be your simple columnar epithelium. This is going to be your submucosa. This is going to be your muscularis externa. In the muscularis externa, in the stomach, instead of inner circular, outer longitudinal, we're going to have three layers now. Okay, so we're going to have innermost oblique muscle, which is this. This is going to be innermost oblique. Okay, and then you're going to have inner, or basically middle, inner circular. So basically there's going to be inner circular and outer longitudinal, but there's also going to be innermost oblique. Okay, so innermost oblique, and then your inner circular and outer longitudinal. So longitudinal muscle, one second, sorry. LM is basically longitudinal, CM is circular, and OM is oblique. Okay, these are the blood vessels, by the way. So in the submucosa, you're just going to see the blood vessels. There are going to be no glands. Okay, now cells of the gastric glands. Really emphasize on your important points. Okay, there's going to be three different types of cells that we're going to cover. We're going to have the mucous neck cells, parenchymal oxynetic cells, and chief peptic cells. Okay, so the main differentiation is their function. What do they secrete? Okay, so mucous neck cells, from their name, they secrete mucus secretions. They have mucus secretions. Okay, they're columnar in shape. Here you can see these neck cells. They're usually in the neck, like they're located in the neck of the gastric glands or gastric pit, basically. That's why their name is mucous neck cells. Okay, they're in the neck. They're located in the neck. So they're columnar cells, and they're gonna have mucus. They're gonna secrete mucus. The peritile or oxynetic cells are going to be these bulges that you're going to see, these bulges, okay? And they're going to secrete HCl, which is the major acid that's produced in the stomach, and the intrinsic factor. Okay, so hydrochloric acid as well as the intrinsic factor. You have the chief or peptic cells, and they're usually basally placed. Okay, they're at the basal layer, and they secrete pepsinogen as well as gastric lipase. You really need to know the functions and what they release. So mucus cells, mucus, they secrete mucus. Peritile oxynetic cells, they're going to release HCl. So take it as, okay, peritile cells are the parent of the stomach. The parent of the stomach releases HCl because HCl is the major producer or major production of the stomach, you know? So peritile cells, HCl. Chief peptic cells are pepsinogen or gastric lipase. This is just a distinction between each of these cells and what they're going to look like. So parenchymal cells are going to look pink. So you can see here, they're just going to look pink. Whereas Chi cells are going to look purple bluish, okay? Parenchymal cells are just going to look pinkish. And they also have like a fried egg appearance. And these are in the neck of the gland. These are in the upper or the middle. And these are in the deep. And then what they secrete, very important. Now, from the stomach to the duodenum. Okay, So there was one distinction where we said, okay, esophagus to the stomach, and now we're talking about from the stomach to the duodenum, okay? So this is the junction between the pylorus and the duodenum. Pylorus is basically the lower part of the stomach, okay? So this is where there's also thickening of the muscle there at the junction due to the pyloric sphincter, okay? And the mucous membrane in the duodenum has intestinal villi. From the esophagus to the stomach, it was the rogae that we were looking at, and from the stomach to the duodenum, what we're looking at is the intestinal villi. Okay, so you see, it's more clear if you look at from far away. If you see these are your intestinal villi. Okay, so here these are your rogae, and these are your intestinal villi. Okay, and then very important to know, duodenum also have Berners glands. Now, Berners glands are present in the duodenum. These small things you see are Berners gland, and they basically, their secretions, they drain into the crypts of Leiberkühn. You can't really see the crypts of Leiberkühn here, but Berners glands is very important to remember. One is Berners glands and one is Ibner's gland, the circumvallate papilla of the tongue. Super important to remember. You guys can differentiate it and basically gain a point in the OSPE from that. Appendix. Very important. Does anybody have any questions for the stomach or the histology of the stomach? Wait, one second. What is the difference between basophilic and eosinophilic? Okay, basophilic this is basically just the staining of H&E, okay? So if it's basophilic stained, it's going to appear as bluish purplish. If it's eosinophilic, it's going to appear as pinkish. It's going to be more lighter if it's eosinophilic. So if something in a question it says, oh, the cell was eosinophilic, that basically means it was pinkish. Okay, basophilic it was more purplish, bluish. The way I remember it is baso, B, so blue, purple. You're welcome. Okay. Does anybody have any other questions? Guys, appendix is a really important slide because I neglected it and it came in my exam, so don't neglect it. It's really important. Just one slide, but it's really important. So don't get confused between the appendix and the esophagus, first of all, okay? Do not get confused. So this is the appendix, okay? And when you zoom in, there's going to be mucosa, some mucosa, muscularis externa, and the serosa, okay? The one thing you're going to see, which is the marking difference, is it's going to have large lymphatic nodules, okay? So you're going to see large lymphatic nodules in the appendix, because appendix is basically the organ that takes your bad stuff, from the body. So it basically kind of like filters everything out. So it's going to have large lymphatic nodules in it, okay? There's going to be muscularis externa with intercircular aorta longitudinal. There's going to be submucosa. There's going to be mucosa. And below the mucosa, like between the submucosa and the mucosa, you're going to see lymphatic nodules, okay? Another very important point is it's going to have goblet cells. Goblet cells in the appendix are for mucus. Okay, so if something's zooming in like this, it's goblet cells. And goblet cells are present in the mucosa. Okay, they're not present in the submucosa, they're present in the mucosa. That's pretty much it for appendix. It's not really a lot, but frequently asked. Is everything clear? Okay, I think everything's clear. We're gonna have a practice questions for this as well, which is the stomach and the appendix. So, which part of the stomach is continuous with the pyloric canal? Sorry. Pyloric antrum, okay. Good. Now, hepatic artery proper, okay, supplying the liver is a branch of which artery? Common, good, okay. Now, what is the name of the common lymph nodes where all the lymph is collected from all the pathways of the stomach and it reaches celiac? Yes, very important, guys. Just remember celiac. Okay. Now, this is taken from the funded glands of the stomach, okay? Now, name the cells that are circled and what is the function. So these are eosinophilic, by the way. Okay, what do they secrete? HCl. Good job. MashaAllah, guys. You're so good. Okay. Name the organ. Appendix. Okay. And name the cell. Goblet. Can you tell me what goblet secretes? Mucus. Amazing job. And that's pretty much it for my part. Now Adam's going to take over and explain you guys the small intestine, the large intestine, the anal canal, the rectum, and yeah.
Okay, perfect. So we're going to start with the small intestine. So the small intestine is divided into three parts. You guys definitely know them by now. The first one is the duodenum, second is the jejunum, and third is the ileum. Okay? So all of the duodenum is retroperitoneal except for the first inch. Do you guys know what the first inch is? Is it retro, intra, or extraperitoneal? Intraperitoneal. Okay. So why is it intraperitoneal? Because it's inside the hepatoduodenal ligament. So the hepatoduodenal ligament surrounds this part of the duodenum. That's why it's intraperitoneal. The portal triad also runs inside of the hepatoduodenal ligament. Do you guys know what the hepatic triad is? Okay. What is it? What are the three structures inside of it, or that make it up? Okay, exactly. So the portal triad runs through this ligament, and the hepatic triad is made up of the portal vein, the hepatic artery, and the common bile duct. The mnemonic that you guys already memorized is VAD. This mnemonic is from posterior to anterior. If I ask you, give me the hepatic triad from right to left, what is the mnemonic you're going to give me? DVA, exactly. So from right to left, it will be the common bile duct, the portal vein, hepatic artery proper. Okay? Moving on. Let's say that you have an ulcer or an injury for the first part of the duodenum. What will this cause? It will cause damage to the gastroduodenal artery. Look at this picture right here, okay? This is the pyloric junction. So now we have the pylorus joining into the duodenum. This is the first part. Posterior to it, you have the gastroduodenal artery. So any injury to this part of the duodenum will cause an injury to the gastroduodenal artery. This is a high topic, keep it in mind, okay? So what are the relations of the duodenum? I'm going to go over the relations very quickly because you need to memorize these relations from your anatomy lectures. So go back to your anatomy lectures, memorize them really well because they might ask you about them in the MCQ and in the OSPE as well. I'm going to go over them really quick. So anteriorly, we have the quadrate lobe of the liver and the neck of the gallbladder, which is this one right here. Posteriorly, we have many different structures. First off, you have the lesser sac. We have the gastroduodenal artery that we talked about. We have the bile duct. We have the portal vein, and we have the inferior vena cava. Okay? Moving on. Superiorly, so above the duodenum, we have the epiploic, omental, or Winslow's foramen. These are all different names for the same structure. We're going to talk about this foramen in details in the next slide, but superiorly to the duodenum is the epiploic foramen. Inferiorly, we're going to have the pancreas. Okay? So, what is the epiploic foramen? It's basically, one second, let me remove this. Okay. The epiploic foramen is basically a foramen. It means that it's an open space. So this foramen is a communication between the greater and the lesser sac. That's its function. What is its relation? Anteriorly, we have the hepatoduodenal ligament. So if you look at this guy's finger, it's going through the epiploic foramen. Okay? So anterior to his finger, we have the hepatoduodenal ligament. Inferiorly, below it, we have the first part of the duodenum. Behind it, posteriorly, we have the inferior vena cava. And superiorly, we have the caudate lobe of liver. Now, keep in mind, the epiploic foramen superiorly is the caudate lobe. And this lobe is different from the quadrate lobe that covers the duodenum. Don't get the two different lobes confused. Do you guys have any question about what we talked about until now? Is it all clear? Okay, perfect. So moving on, we're going to go into Collard's triangle. What is Collard's triangle? It's an area that surgeons use in order to perform a type of surgery called the cholecystectomy, which is the removal of the gallbladder. Okay, this triangle is made up of three different structures. These three structures will make the borders of this triangle. Superiorly, we have the cystic artery. Inferiorly, we have the cystic duct, and medially, we have the common hepatic duct. Okay. However, some of my first year friends, they told me that in your labs, they told you that the posterior part is made up of the liver. So in your exam, it's better to be on the safe side, write liver, and then in brackets, write cystic artery. That way, you're gonna guarantee your point. Okay. So again, what is the importance of this triangle? If a surgeon is doing a surgery to remove the gallbladder, it allows for safe dissection of the cystic duct and artery. And let's look at the cadaver. So if you can confirm this is the gallbladder. So what goes out of the gallbladder is the cystic duct. And what comes from the liver, the hepatic duct. So now we knew where the cystic duct and the hepatic duct are. And we already know that the hepatic duct is medial and the cystic duct is inferior. So this part right here, where the arrow is pointing, this will be the Collett's triangle. Okay? Is this concept clear? Do you want me to go over it one more time? Can you point at it again? Okay, wait, I'm gonna use the laser pointer to make it clear. Okay, so we have the cystic duct right here, right? We have the hepatic duct right here. Hepatic duct is medial, so we're gonna now look at the lateral part, which is the entire area right here. And the cystic duct is inferior. So we're gonna look at this area right here, okay? Now we know that the liver is here, and the liver forms the superior border of the triangle. So this part right here, this is the triangle, Collett's triangle. You can kind of see it like this, you know? That's the Collett triangle. Did you get it? Perfect, okay. So moving on, we're gonna talk about the duodenal papilla. Before I talk about it, do you guys know what this duodenal papilla means? Exactly. So it's basically openings into the duodenum. Now, what goes into these openings? First off, we have the bile duct and the pancreatic duct will enter the second part of the duodenum through the duodenal papilla. We have two duodenal papilla, okay? The first one is the minor duodenal papilla, and this minor duodenal papilla will be an opening for the accessory pancreatic ducts. We're going to talk about it when we come to the pancreas. But the accessory pancreatic duct will open into the minor duodenal papilla, and it does not always have to be there. Sometimes the accessory duct will also join with them, with the other ducts. And the other duodenal papilla is the major. The major duodenal papilla is where the ampulla of Vater will open, which is basically the common bile duct and the hepatic duct will connect with the pancreatic duct and open into the duodenum, which is this one right here. On this opening, on this papilla, you have the sphincter of Oddi, which is basically the muscle that contracts and relaxes in order to release the secretions. Okay? Do you guys have any questions about that part? Okay, nice. So now we're going to talk about the jejunum and the ileum. So what is the difference between the jejunum and ileum? The vasa recta in the jejunum is longer than the ileum. So what is the vasa recta? Basically, you have the main arteries right here, okay? The vasa recta is the longest part, the one that connects the intestine itself to the last portion of the arcade. So this artery right here is called the vasa recta. In this part, in the ileum, the last part of the arcade, which is this one right here, this is the vasa recta of the ileum. So in the jejunum, the vasa recta is longer and it has fewer arcades. In the ileum, the vasa recta is shorter and it has many arcades. Now, what about the pulci circularis, which are basically the circular folds? In the jejunum, there are more pulci circularis than the ileum. What about the lymphoid nodules? The jejunum has fewer than the ileum. And something that's also important for you when they give you the OSPE question, because they're going to give it to you on a cadaver. So you're not going to be able to tell them lymphoid nodules. So you're gonna tell them either vasa recta, arcades, jejunum has more pulchri circularis, and more fat. Okay, they're gonna probably ask you to name 3 differences. So the best 3 to name are the jejunum has longer vasa recta, fewer arcades, and more fat. Or you can say that the ileum has shorter vasa recta, more arcades, and less fat. Okay. Now, this is an important note. The pulchri circularis is found in the entire duodenum except for the first inch. Okay, keep that in mind. Let's look at pictures right now. Can you guys tell me which one is duodenum, which one is duodenum, which one is ileum? The right one is duodenum. Ileum has more fat, not less. The ileum has more fat. Wait, let me double check. Okay, yeah, okay. Sorry guys, there's a mistake. So the ileum has more fat and the duodenum has less fat. I'm gonna send you the updated slides after the session. But thank you for pointing it out. So the duodenum has less fat, the ileum has more fat, okay? So back to the question. Okay, yeah, you got it right. So the left one is the duodenum and the right one is the ileum, okay? And this is another picture from our lab committee, the duodenum and the ileum from a different cadaver, okay? Now, we're gonna go into the histology. Is the anatomy part clear? The arcades, yeah, okay. Do you see this line that connects the ileum? It's not really clear in this picture on the cadaver, but it's gonna be really clear in the OSPE. And if you can look at this one right here, you can see that the arcades are only on this part right here. It's really close to the main artery that supplies them. And the vasa recta is really long. Whereas if you look at this one right here, it's kind of shorter. Like you can see this one ends here. So there's probably an arcade here. Okay. In the OSPE, it will be way clearer, but probably it's only the pictures that don't show them really well. Okay, yeah, this one is really clear. So you see the arcades, many different arcades really close to the intestine itself. Whereas here, this is the only arcade, and this is the long vasa recta. Okay. Any other questions? No problem. Okay, so let's go into the histology. Now, for the histology, I'm not going to be explaining everything for you guys. I'm just going to tell you the important Okay, wait. I'm going to help you guys differentiate between the different parts of the intestine. Okay, so let's start with the duodenum. The pulchri circularis, they are basically folds of mucosa and submucosa. So in this image right here, this entire structure is the pulchri circularis. Okay, and as we said, it is not present in the first part of the duodenum. It's visible in the jejunum, and it's less prominent in the ileum. So middle, highest, and least. The duodenum has a couple of pulchri circularis. Jejunum has a lot. Ileum has very little. Okay. Now moving on, the epithelium. Keep in mind that all of the intestines, both small and large, have simple columnar epithelium. Okay. We're gonna now talk about the crypts. They are basically innervations or like how do I say it? A valley between two hills. Okay, so you see the villi right here. There's a valley between them. This is called the crypt. Okay, so the crypts of Libercon, they receive the secretion from Brunner's gland. This is the most important thing you need to take out of this slide. In the duodenum, you have the Brunner's gland. What is the Brunner's gland? It's a serous gland in the submucosa, and it drains its secretions into the crypt of Libercon. You need to memorize this really well, because if they're going to get you a picture in the histology station, it's probably going to be this one, and they're going to tell you which part of the intestine are you in and how did you know. You're going to say the duodenum because there is the Brunner's gland. Okay, this is the most important thing that you guys need to take out of the slide. Now let's look at this picture right here. There are a couple of goblet cells. What are goblet cells? They are basically, let me show you on this slide. They are basically these white structures on the villi, like on the surface of the epithelium. And there are very little in the duodenum. As you move on in the intestine, they will keep increasing in number. Okay, so in the duodenum, we have very little goblet cells. What observe the goblet cells? What is the goblet cell? It's basically they secrete mucus, and in the duodenum they are closer to the surface. Okay, so appreciate how they are really close to the surface, and that's it for the duodenum. Let's move on to the jejunum. So the jejunum does not contain the Brunner's gland. We already said it's only found in the duodenum. And what's the difference between rugae, which is the foldings that are found in the stomach, and the pulchi circularis, which are the foldings found in the intestine? Pulchi circularis cannot completely flatten when the intestinal wall is distended. When you eat a lot of food, your stomach can widen really big until it's completely flat. The intestines cannot do that. Okay? Now, the jejunum, what is really important to know about it? The Paneth cells. What are they? They are eosinophilic. Basically, it means that they are red when you stain them. They are eosinophilic cells at the bottom of the crypts. So if you look at the crypts right here at the bottom, there are these really red cells. These are the Paneth cells. What is their role? Their role is in the innate immunity. Okay? Let's look at the pulchi circularis of the jejunum. It's this entire fold. So it's basically one upward invagination. Okay? And that's mainly it for the jejunum. That's how you differentiate it from the others. Moving on to the ileum. So the ileum, the differentiating factor is the Peyer's patches. That's it. The ileum and the jejunum are exactly the same. The only difference you can see in the ileum is the Peyer's patches, which are basically nodules of lymphatic tissue, meaning they have a function, they function in immunity. Okay? And where are these Peyer's patches? You can see them right here. They are basically like a circle with a lighter center. Okay? So the second you see Peyer's patches, you are in the ileum. Okay? Now, if you realized, as we moved on from the duodenum, we have a couple of goblet cells here. The jejunum, we have a couple more of goblet cells. You see them right here, a couple more. When we go into the ileum, look at how many goblet cells we have. So the more you move in the intestines, the more the goblet cells will appear, and the more the whiter the lining will become. Okay? Let's look at the larger picture now. This is the Peyer's patches. Okay? It's basically like a lot of nucleuses around, and this center right here is like a circle. You can't really see it because there's the covering on it. The PP is covering it. But it's like basically a lighter circle in the middle of many different cells. Now, another way for you to differentiate between the duodenum and ileum, the duodenum, the border of the duodenum, basically looks like there's a couple of hairs on it. Whereas the jejunum looks like there's a lot of droplets and it's broken down and it's not really neat. It's not connected. The ileum looks like waves. It's basically a wave coming and then it flattens down. Okay? In the OSPE, you can't tell them that this is how I knew. This is just for you to know that this is the ileum. And then you can tell them the differences between them. Okay? And this is the table that summarizes everything. So we said duodenum, it has the broadest, slightly shorter than jejunum and ileum. Narrower, you're not going to really know this, just skip over it. The Brunner gland is present only in the duodenum. Peyer's patches present only in the ileum. Goblet cells, least, average, most, so they keep increasing. And the pulchi is less prominent. It's more prominent, it's the most prominent in the jejunum, less prominent in the ileum. It's the least dominant, prominent in the duodenum. That's what it should say. So least prominent, or no, wait, the least prominent is in the ileum, sorry, okay? So most prominent jejunum, the middle is the duodenum, and the least is the ileum, okay? Do you guys have any question about the histology part? We're gonna move on from the histology of the small intestine. Again, I did not go into the functions because that's more of the lecture part, but I'm just gonna help you guys differentiate between the different structures. Okay, I'll take that as no questions. So moving on, we're gonna move into the ligament of Treitz. What is this ligament? It supports and anchors the duodenum, to be more precise, the fourth part of the duodenum, and helps move contents along the gastrointestinal tract. So the fourth part of the duodenum is supported and anchored by the ligament of Treitz. Where does this ligament originate? It originates from the right cross of the diaphragm. This is important to know as well. Okay, ligament of Treitz origin is the right cross of the diaphragm. Why is it important? Let's say you have a birth defect in this ligament. What will happen? The duodenum will fall down. So you're going to have intestinal malrotation, which is twisting. You're going to have problems in the GI, basically. Okay? Now, I'm going to give you a quick overview on the circulations of the intestines. So the foregut, what artery provides arterial supply to the foregut? Celiac. Okay, so basically the celiac trunk. And what does the celiac trunk provide arterial supply to? The lower third of the esophagus, stomach, pancreas, spleen, liver, gallbladder, and half of the duodenum. The midgut, what is the main artery that supplies them? Superior mesenteric, exactly. Wait. Okay, superior mesenteric artery. What does it supply exactly? The other half of the duodenum, jejunum, ileum, cecum, ascending colon, and 2/3 of the transverse colon. The hindgut, what is the main artery that supplies it? Inferior mesenteric, exactly. And what does it supply exactly? The last third of the transverse colon, the ascending colon, and anal canal. Okay? We're going to go into more details about the blood supply at the very end, but just bear with me for now. Okay, here's a question. Which of the following structures is the continuation of the duodenum? Is it A or B? A. Okay, why is that? Give me three reasons. Long vasa recta, that's one. Less fat, two. Fewer arcades, three. Exactly. Okay. Easy question. They probably will get it on your OSPE because it's really repeated and it's a really high yield. So that's really 3 marks. Okay. Three differences, and you already know which one is the ileum, which one is the jejunum. Question 2. What part of the intestines are we in? And how did you know? Duodenum, duodenum, duodenum. Okay, how did you know? Brunner's gland, exactly. So we are in the duodenum, and how do we know? You can see the Brunner's gland right here. Okay, and that's it, I think. Yep, we're gonna go into the pancreas now. Is there any question about the small intestines? Anything at all? Anatomy or histology? Okay, I'll take that as a no. So let's go into the pancreas. So let's look at this picture right here. We have the head of the pancreas, the eucinate process of the pancreas, neck, body, and tail. Now I want you to tell me, is this the posterior view or is it the anterior view of the pancreas? Posterior view, exactly. So this is the posterior view of the pancreas, okay? Now let's look at this picture right here. Let me bring a pen. Okay. This is the spleen, right? What is this artery right here? And you're gonna definitely get the question about this. What is this artery right here? Splenic artery, exactly, okay? So let's look inside of the pancreas now. You have this duct running across the entire pancreas. What is the name of this duct? Duct of Wirsung? This is called the main pancreatic duct or the duct of Santorini, okay? That's the other name for it. Main pancreatic duct or the duct of Santorini. And from this duct, you have something going out of it. Isn't Santorini? Santorini is the main. Wait, let me check. I got this from one of the committees. Let me check. No, the main pancreatic duct is the duct of Santorini. One of the images on Google is saying that. Yeah, saying that. There's another image. Okay, wait. I'm gonna come to it at the very end because there are different resources saying one worse and one Santorini. So I'm gonna come to it at the end. Okay. Let's continue for now. So the relations of the pancreas. The anterior part of the pancreas is covered by the pyloroduodenal junction. So the pylorus, which is the stomach and the duodenum, transverse colon, and root of the transverse mesocolon, which is this structure right here. Everything is on this picture. Posteriorly, we have the beginning of the portal vein, which is right here, and the bile duct. superiorly, inferiorly, and laterally is covered by the duodenum. First part of the duodenum, superiorly, inferiorly is the third part, and laterally is the second part. Okay. Now, for the uncinate process, and anteriorly to the uncinate process, we have the superior mesenteric vessels. This is really high yield. Okay, so anterior to the uncinate process is the superior mesenteric vessels. Posteriorly is the abdominal aorta. Okay. So the neck of the pancreas, anteriorly we have the pylorus. Posteriorly we have the superior mesenteric vein and the portal vein. So basically when they join together, the superior part is covered by the first part of the duodenum, the structure right here, and inferiorly we have the root of the transverse mesocolon. Again, go back to your lectures for this because they probably explained it in more details there, and everything you need to know is probably in the lectures. Okay. So the body of the pancreas, anteriorly we have the root of the mesocolon, posteriorly superior mesenteric artery, the left cross of the diaphragm, the renal vessels, and the splenic vein. Superiorly to it, you're gonna have the celiac artery, hepatic artery, and the splenic artery. Inferiorly, you will have the superior mesenteric vessels and the duodenojejunal flexure. Okay, so do you have any questions about the anatomy other than the pancreas ducts? We're going to come to it at the end. Okay, so let's go into the histology. So the pancreas, we're going to talk about the exocrine part. There is something called the centroacinar cell, which is this cell right here, the white part. Okay, let me put it on. The white part right here. This is the centroacinar cell. It is part of the duct system that starts from within the acins. Okay, how do you know that this is the centroacinar cell? Basically, you have a white center surrounded by pink matter, and it is bordered by these cells right here. What is the name of these cells? They are the secretory acini, SA. Okay, so secretory acini will surround the pink matter, which will surround the white area, which is the central acinar cell. Okay, that's how you know you're in the exocrine gland. Now, how do you know you're in the pancreas? You will have islets of Langerhans. That is the main differentiation for you to know that you're in the pancreas. Islets of Langerhans. Okay, so acinar or pyramidal cells, they secrete pancreatic juice. Okay, that's all you need to know, that the acinar cells secrete pancreatic juice. Let's take a closer look at the endocrine and the exocrine. So the exocrine pancreas, we said we have islets of Langerhans. We have the central acinar cells, which is the white area surrounded by the pink matter, bordered by the secretory acini. And you have the interlobular and intralobular. What's the difference between intra and inter? Intra means within, and inter means between. Okay, so let's say I have structure 1 and structure 2. Intralobular means that the duct is passing in it. Interlobular means it's passing between it. Okay, so that's the difference between intralobular and interlobular. So if you look at this duct right here, this is the intra or inter, wait, let me check. This is the intralobular, yeah. So it's intralobular because it's passing within the ducts. Now let's look at the endocrine pancreas. The only picture I saw in your lectures and in the lab was this picture right here for the endocrine. And how do you know that this is the pancreas? Islets of Langerhans, islets of Langerhans, islets of Langerhans. And there is this white line that kind of cuts it into different lobes. You see how there is many different lobes? This is called the septae. Okay, so if you see septae dividing the pancreas into different lobes, you know you're in the endocrine pancreas. Okay, any questions about this? Difference between the interlobular and intralobular duct. Okay, I'm gonna explain it in more details. So let me just clear the drawings. You have structure 1, okay, and you have structure 2 right here. Basically, when I say intralobular, that means that I am going within something. Okay, so when I say intralobular, that means within. Interlobular means between. Does that kind of explain it, or do you want other details? Because they're not going to really ask what's the difference between them. They're just going to tell you intra or interlobular. Okay, perfect. So what is the difference between the pancreas and the parotid gland? This is a really important topic, and it's really high yield. And they talked about it in the file they sent, which is the important OSPE questions. So the pancreas, we said the most important difference is the islets of Langerhans. They are only found in the pancreas. And you have the central acinar cells, which we talked about. In the parotid gland, you have adipose cells. Adipose cells will appear white, or fat droplets. Adipose means fat, okay? So you have fat droplets, and you have striated ducts. The ducts have striations. I'm not sure if we can see them. Okay, yeah, you see the many different nucleuses. This means that they are striated. It's not simple, okay? They are striated. That means you are in the parotid gland. The second you see adipose cells, you're in the parotid, okay? So what can be found in the anterior part of the pancreas? Do you guys memorize it or not yet? Anterior part, anterior to the head of the pancreas. Transverse colon, okay, nice. Okay, so there are three structures. Transverse colon is one, pyloroduodenal junction, and the root of the transverse mesocolon. Okay. Question 2. What organ is this, and how could you tell? Pancreas. Central acinar islets of Langerhans, exactly. So this is the pancreas. You can see the islets of Langerhans, which are these white structures right here, the white circle. And you can see the central acinar cells, which is the white area surrounded by the pink matter, surrounded by the secretory acini, right? Yeah, secretory acini. Okay. We're done with the pancreas. I'm going to go back at the very end again for the ducts of the pancreas. I'm going to tell you about them at the end. I'm going to double check with your lectures. But for now, do you have any questions about the pancreas? Okay, perfect. So the large intestine, this is the fun part of the GI. So the large intestine is divided into 9 different parts. You have the cecum, appendix, ascending colon, transverse colon, descending colon, sigmoid, sigmoid rectum, and then you have the upper half of the anal canal. Okay, why did I say the upper half? Because the lower half is from different embryonical origin. It has different supplies, it have different innervations. Okay, so the cecum is the beginning of the large intestine, and we can find the appendix and under the cecum. We have the ileocecal junction between the cecum and the ileum. Ileocecal junction, ileum and the cecum. It's where the ileum will open into the cecum. On the cadaver, this is the cecum. I got it from our batch as well. And this is the appendix. Now, can you appreciate the artery that supplies the appendix? It's called the appendicular artery. But what is the origin of this artery? Where does it come from? Ileocolic, exactly, okay? So, appendix, what is the most common position you're going to find the appendix in? Retrocecal, exactly, okay? So, retrocecal is the most common position for the appendix. They're not going to tell you the second most common, the third most common. The question will most probably come as the most common position. So, appendicular artery is found on the free margin. What does free margin mean? It means in the area that's not really connected to anything of the appendix, and it's the branch of the ileocolic. And the mesoappendix. The mesoappendix is basically this entire area. Wait, let me put a pen. This entire area right here that you can see the flashlight in. This is the portion of the mesentery that connects the ileum to the appendix. What does meso mean? It basically means fake. So this is a fake mesoderm. Why is that? Because it's not attached to any different walls. Okay, so it's not attached to any walls. That's why it's called a fake meso. You get what I mean? Moving on, the colon. After the cecum, we have the ascending colon. And the colon, before becoming the transverse colon, it will bend on the right side of the body, which is called the right colic flexure. And what do we have on the right side? We have the liver. So another name for it is the hepatic flexure. After that, we have the transverse colon. And the transverse colon has something really important, which is the mesocolon. What is the mesocolon? It's basically a structure that attaches the transverse colon to the posterior abdominal wall, keeps it in position. Okay? After that, the transverse colon will bend on the left side of the body, left flexure, where the spleen is found. So the other name for it is splenic flexure. And then it will continue into the descending column. Okay? Now, let's talk about the lesser omentum. The lesser omentum is double layered. It's made up of 2 layers. Okay, this is really important. The lesser omentum, 2 layers. The greater omentum is made up of 4 layers. Okay, so the lesser omentum, it is made up of the hepatogastric ligament, which is this part right here, hepatogastric ligament. It connects the liver to the stomach. Hepato, liver, gastric, stomach. The other part is the hepatoduodenal ligament. Hepato means liver, duodenal means duodenum, and it connects the liver to the duodenum and contains the portal triad that we talked about. Okay, what is the function of the lesser omentum? It anchors the stomach and liver in the abdominal cavity. Now let's go into the greater omentum, and this is really important for you guys to know. The greater omentum, it connects the greater curvature of the stomach to the transverse colon. It consists of 4 layers of peritoneum and covers all of the intestines. What is the function of the greater omentum? We have immune contributions. They have a lot of macrophage collections, so they contribute to the immune system. And this is the word that you keep carrying around, the policeman of the intestines, policeman of the intestines. They have infection and wound isolation. It physically limits the spread of the intraperitoneal infections. So if you have a GI infection, it will physically stop this infection from spreading to other organs. Okay? The greater omentum is dorsal is the origin of the greater omentum is from the dorsal mesogastrium. Okay, this is really important as well, because they might ask you in the OSPE, what is the origin of this? What is the origin of this? So please go over your embryology lectures before you go into the OSPE. Now, the large versus the small intestine. Can you guys tell me the 3 differences between the large and the small intestines? Large don't have continuous longitudinal muscle. Okay. Tinea coli, epiploic appendages. Large doesn't have villi. Okay, I'm talking more anatomically, not histologically. Okay, so the first difference is the epiploic appendages. What is an epiploic appendage? It's basically an outpouching of fat-filled serosa-covered structures. You don't really need to know the definition, but they are basically attached to the wall of the large intestine, and they function in the protection. This is what they look like. The epiploic appendage, they are basically the yellow structure that is going outside of the large intestine. The other difference is the tinea coli, which is basically the incomplete outer longitudinal muscle. We have 3 tinea coli in the large intestine. And the third difference, is the hostra, and another name for them is the saculations. Now, what is a hostra? It's basically these different circles. So each circle is called the hostra. So in the large intestine, you have hostra, epiploic appendages, and tinea coli going along the muscle. Okay? Is it clear, or do you want me to go over it again? Any questions for anything before? Okay, so moving on, this is some of the embryonic lectures that I put into the slide, but that's the most I could get. What is the gene coding for the transcription of the duodenum? What do you guys think is the answer? PDX1, okay. What is the gene coding for transcription of small intestine? CDXA, CDXC. Small intestine is CDXC. What is the gene encoding for the large intestine and the rectum? CDXA. Okay, so look at large and look at small. The A in large is before the A in small. So that's how you know that for the large intestine, it's CDXA, and the small is CDXC. What about the gene for the esophagus and stomach? SOX2, exactly. Okay, so let's go into the histology now. The appendix, let's look at the mucosa of the appendix. Okay, we have simple columnar epithelial cells. However, they have a special name in the appendix, which is colonocytes. Okay, The appendage, the columnar epithelial layer of the appendix is called colonocytes. What about the submucosa? The submucosa contains a very important structure, and that is the best way for you to know that you're in the appendix. They are the most conspicuous feature of the appendix are the large lymphatic nodules, which are these structures right here, extending till submucosa. Basically, lymphatics, anything that has lymphatics in it is basically related to the immune system. So you have a circle with many different dots inside of it. This is a lymphatic nodule. Okay. If you look beside it, you're gonna have many continuous dots until suddenly you have a circle with dots in the middle and free spaces. This is a lymphatic nodule. If you see a lymphatic nodule, this means that you're most probably in the appendix. Okay. What about the muscularis externa? We said that Taenia coli in the large intestine has three parts, three muscles. In the in the appendix, these Taenia coli will join together and they will fuse there. So in the muscularis externa, you will have the inner circular and outer longitudinal muscle layers. You can't really see them on the histology slides, so don't worry about it for now. Moving on to the colon, we have the crypts of Libercon, which we already know. We have all of these different structures, and we have the galt. This is the most important thing you need to know about the colon. Okay, what is galt? It's gut-associated lymphoid tissue. This big structure right here. Okay. Now, for you to know the difference between the colon and the ileum, jejunum, and whatever, you see these teardrops. If you see teardrops, then you know you're in the colon. Okay. And then you know you're in the colon, you're going to search for galt. So when they come to you in the OSPE, they're going to tell you, what is this? Which part of the intestines are you in? You're going to tell them, we are in the colon because there is galt. Okay. Here is still the same thing, globular cells, colonocytes. Okay, there's nothing to know there. Colon, okay. So in the submucosa of the colon, you have larger blood vessels, lymphatic vessels, nerve fibers, and you have Meissner's plexus. You see this small kind of triangular structure right here? This is called the Meissner's plexus. You need to know this as well, because this is one of the differentiations that you need to know about the colon. Okay, so Meissner's plexus is found in the colon. Now for the serosa is this, wait, you see this white line here? This is the serosa. It's not this lining, the pink lining, it's the white lining, okay? So it's simple squamous epithelium, visceral peritoneum, and the serosa is continuous with the mesentery of the appendix, okay? Do you have any questions before we move on? Okay, so let's move on to the anal canal and the rectum. So the terminal part of the GI consists of a rectum and anal canal, which are derived from different embryonic structures. The rectum extends from you don't need to know this. So we have three lines that we need to know. The first one is the anorectal line. It is the junction between the anal canal and the rectum. So we have the anal canal and the rectum. The junction between them is called the anorectal line. Then we have the pectinate line, which is where the upper half of the anal canal joins the lower half. It's basically this line that goes right here. Then you have the anocutaneous white line, which is the transition between keratinized and non-keratinized stratified squamous epithelium. Keratin on the skin, the main function of it is protection. Okay? So when you're deep inside of the body, you don't really need protection from anything there. So that's why in the upper half in the upper part of the anal canal, you don't have keratinized squamous epithelium. You have it in the lower part. And how do you know you have squamous epithelium? It's because of the anocutaneous white line. Okay? So anorectal line, the rectum separates from the anus. Then you have the pectinate line, the upper half from the lower half of the anal canal, and the anocutaneous line, the upper part from the lower part of the stratified squamous epithelium. Here we have keratinized, and here we don't have keratin. Now let's talk about the sphincters. We have two sphincters. We have the internal anal sphincter and the external. The internal is under autonomic control. That means it's involuntary. You cannot control it. It is the thickened lower end of the inner circular muscle layer of the gut. So you see the muscular layer of the gut, how it's coming down. Then you have the thickening of it. This will make up the internal anal sphincter. It's continuous with the muscles of the gut. And what nerve innervates it? The inferior hypogastric plexus. You need to know the nerve that innervates the internal and the external. It's really important, okay? So the internal is innervated by the inferior hypogastric plexus. Now the external, it's under somatic controls, means I can control it, it's voluntary. And it has three parts. the deep, superficial, and subcutaneous. These three structures will make up the external anal sphincter, and the external anal sphincter is innervated by the inferior anal branch of the pudendal nerve. Okay, memorize the nerve, pudendal nerve. Okay, so you should be able to identify everything on this structure. First off, we have the ascending colon, the right colic flexure, transverse, left colic flexure, descending, and then you have the sigmoid colon, and then you have the rectum. Okay, and this is a summary table. Basically, you have the development. Wait, let me go through it really quick. Okay, so let's look at the development. Upper anal sphincter comes from the endoderm. The lower comes from the ectoderm. Upper is innervated by autonomic, which is the pudendal nerve. Wait, no, the internal is by the inferior hypogastric plexus. The lower or the external anal sphincter is by somatic nerves, which is the pudendal nerve. The epithelial lining is simple columnar in the upper, certified squamous in the lower. The arterial supply for the upper comes from the superior rectal artery. The lower comes from the inferior rectal artery. And you need to know from where these come from. So this one comes from the inferior mesenteric. I think this one comes from the iliac. I'm not sure. Venous drainage, this one drains into the portal system. This one drains into the caval system. What does caval mean? Means the cavas, the inferior vena cava, superior vena cava. That's what caval system is. Then you have the lymphatic drainage. The upper will drain into the internal iliac, while the lower will drain into the superficial inguinal lymph nodes. And the hemorrhoids, for the upper, it's internal and it's painless. For the external anal sphincter, it's external hemorrhoids and it's painful. Okay. Now, what are the relations to the rectum and the anal canal? In females, anterior to them, you have the vagina and the uterus. And then anterior to the vagina and uterus, you have the bladder. In males, you have the prostate gland, and then you have the bladder. Okay? Any questions so far? Okay. Okay, now let's look at this picture right here. The cecum, it's intraperitoneal. Okay? Ascending colon, retroperitoneal. Transverse colon, intraperitoneal. Descending, retro. Sigmoid, intra. And then you have the superior part of the rectum. It's not intraperitoneal, okay? It's intraperitoneal-like. So in the exam, if they ask you what is the superior part of the rectum, intraperitoneal, retroperitoneal, or exoperitoneal, say retroperitoneal. Okay. Then you have the rectum, which is retroperitoneal, the middle part of the rectum, and the lower part is lower third is extraperitoneal. So rectum divided into three parts. The first part, the first third, is retroperitoneal. The middle third is the first third is retroperitoneal. Middle third, retroperitoneal. Lower third is extraperitoneal. Okay? Before we move on to the histology, any questions? Okay, the histology of the rectum and the anal canal are really easy. All you need to know here is that the mucosa is identical to that of the colon, but it has the really long tubular mucosal glands. So you see these really long tubular mucosal glands. This is found in the rectum. The muscularis layer, you don't need to know. Okay, the rectum, it has more goblet cells than the colon. So I told you from the small intestines, as you move on, you're going to have an increase in the number of the goblet cells. So look at these white structures. Let me put a pen. Look at these white structures right here. You see how many there are? When you see all of this, you're going to know you're in the rectum. Okay. So a really large number of goblet cells. Why is that? Why does the rectum have a lot of goblet cells? Because it will cause the fecal matter to pass through them more easily. Okay. This is literally all you need to know for the rectum. That's the only slide you have for the rectum. Then the recto-anal junction. You need to observe the simple columnar epithelium of the rectum. Simple columnar epithelium of the rectum. Wait, let me find a better picture. Okay, right here. You see this simple columnar epithelium of the rectum. It will change abruptly, suddenly. So basically, it's just like a line into stratified squamous epithelium. It's not really clear in this picture. I don't know why, but like you can see, it's like kind of columnar epithelium cells. And then you suddenly have many different dots everywhere. Okay. And if you look at this picture right here, the importance of this picture is that you can see the internal anal sphincter and the external anal sphincter. Okay. And if they give you in the OSPE a really big picture, a really zoomed in picture, such as these two right here, how to know you're in the rectoanal junction? You're gonna see sebaceous glands, many sebaceous glands right here, and you're gonna see hair follicles. How do you know that there's hair or hair follicles? You see these black structures right here? These are basically hairs and hair follicles. And if you look at this structure right here, it's a hair follicle, but the hair is not there. Okay, so this opening, it should have a hair going out. So this is a hair follicle that's missing the hair. But if you see this black structure, like black color, you know that there is a hair follicle there. So you know they're in the rectoanal junction. Okay, and that's it. So who wants to answer this question? Name the marked structure and give its nerve supply. Rectum is retroperitoneal. Yes, the first 2/3 is retroperitoneal. The first 2/3 is retroperitoneal, and the lower third is extraperitoneal. Okay. Internal anal sphincter. Okay. Give the nerve supply. Inferior hypogastric. Exactly. Okay. Now, onto the blood supply. For the blood supply, I did not really go into much details about it because it's very clear in your anatomy lectures. So if you go back to them, it will be very clear for you guys. But I'll go over them really quick. Okay. So first off, we're gonna start with the celiac artery. We have the celiac trunk going out. We have 3 branches from it. The first branch is the splenic artery. The second branch is the left gastric. The third is the common hepatic. We're going to focus on the splenic artery for now. Okay, from its name, splenic artery, it's going to give splenic branches that will supply the spleen. It will also give pancreatic branches that will supply the pancreas. It will give the left gastroepiploic artery, which will go to the greater curvature of the stomach. And it will give short gastric arteries that will go to the fundus of the stomach. Okay, that's for the splenic artery. Now, for the left gastric, it will give the esophageal branches, which will go to the lower esophagus. It will give gastric branches, which will go to the lesser curvature. Okay. For the common hepatic, it's going to give off the gastroduodenal branch, which will give the right gastroepiploic, goes to the greater curvature. Superior pancreatoduodenal, which will go to the pancreas and abdomen. It will give the right gastric, which will go to the lesser curvature. And it will go to the, give a branch of the proper hepatic, which will be divided into left and right. The left hepatic will supply the liver only. The right hepatic will supply the liver, and it will give the cystic artery, which will go to the gallbladder. Okay? Is the celiac trunk clear? Okay. So moving on, let me clear everything. We have the superior mesenteric artery. Okay? The superior mesenteric artery, it will give jejunal arteries to the jejunum, basically. Ileal arteries to the ileum. It will give the inferior pancreaticoduodenal. And the inferior and superior pancreaticoduodenal will form an anastomosis. Okay? It will also give a middle colic branch and a right colic branch. And all of these colic branches, they will form a lot of anastomosis, and they will provide arterial supply to the ascending colon and the 2/3 of the transverse colon. So basically, remember the arterial supply of the jejunum and ileum, you had a lot of arcades. Basically, this is what's going to happen with the right and middle colic arteries. And then it's going to give a colic branch, which will supply the ascending colon, appendicular artery, which will go to the appendix, cecal branches to the cecum, ileal branches to the ileum, and the ileocolic artery itself will form a loop. Okay? Again, I'm going over this really quick because it's in your anatomy lecture. There's a whole lecture about the blood GI supply. Okay. Now, we have the inferior mesenteric artery. The inferior mesenteric artery is going to the left side. Okay, keep that in mind. Superior goes to the right, inferior goes to the left. It will give a left colic branch, which will supply the distal 1/3 of the transverse colon and the descending colon. Sigmoid branches, which will go to the sigmoid, and the superior rectum, which will supply the upper rectum. That's the inferior mesenteric artery for you. Okay. And this is the clear images if you want to go over them. And these are two videos I found that are really helpful. This is the one I used in the illustrations. And this one is really clear because it shows you everything, the stomach and everything. But watch them when you have time because they're really helpful. Now let's talk about the veins, okay? The venous drainage. So drainages do not start from the IVC or the portal vein. They start from the organ itself. So first we're going to start with the superior rectal. It will join with the sigmoid. It will join with the left colic, which is made up of the lower colic as well. And it will all form the inferior mesenteric. So superior rectal, sigmoid, the colic, they will all join to form the inferior mesenteric artery, which is this the inferior mesenteric vein, this vein right here. Okay? Why is it important to know the venous drainage? Because the inferior mesenteric vein will drain into the splenic vein. Okay, this is a really high topic. They might ask you about it in the OSPE. Okay, we're gonna come to that for now. Let's focus on the left gastroepiploic, splenic, short gastric, and pancreatic. All of these will join together to give us the splenic vein. The splenic vein will have the inferior mesenteric vein draining into it. Okay, keep that in the back of your head because it's really important. Now let's go onto the other side. We have the appendicular vein, which will drain into the ileocolic. The ileocolic with the ileal, jejunal, right gastroepiploic, middle colic, and the inferior pancreaticoduodenal, they will all drain into the superior mesenteric. Also the right colic as well, okay? They will all drain into the superior mesenteric vein. The superior mesenteric vein will go with the splenic vein to form the portal vein, which will go to the liver. Is it clear? This is like a really overview of it. The venous drainage literally follows the arterial supply. Okay? Is it clear? Okay. So moving on to the anterior abdominal wall, but before we do that, for the arterial supply and the venous drainage, focus a lot on the splenic artery and the arterial supply to the spleen, as well as the stomach. These are really high topics they're going to ask about in the OSPE. But focus on the arterial and venous drainage of these structures most importantly, and also go over the lymphatic drainage for the GI tract, okay? So anterior abdominal wall, okay? From outside to inside, first we have the skin. Let me remove the chart, okay? First we have the skin, then we have the superficial fascia, which is called the camper, and the scarpas, okay? Superficial fascia contains two fascias, the camper and the scarpa. Camper is the outside most, it's fatty layer, and the scarpa is the inner one, which is the membranous layer, this blue structure right here. After that, we have the deep fascia, then the muscles, the external oblique, internal oblique, and transverse abdominis, and their aponeuroses. Then we have the transversalis fascia, extraperitoneal fat, parietal peritoneum. A mnemonic for you to memorize is supersonic faced many troubles eating pizza. Okay? This is a nice mnemonic for you to memorize all of the anterior abdominal walls from outside to inside. Now, let's take a look at the anterior abdominal wall on the cadaver. We have the scarpus fascia. How did we know that this is the scarpus fascia? Because it's membranous, it's not fatty. Okay? So the scarpus fascia. Then we have the external oblique. When we put the external oblique on its original place, you will find that the lines and the external oblique muscle goes from superior to medial, which is the hands in the pocket motion. The internal oblique, when we close it, it will go in the opposite direction of the external oblique, from superior to lateral. Transverse is just transverse, from like basically horizontal, okay? So the fibers arrangement for the external oblique is inferior to medial. Oh yeah, my bad, okay. External oblique is inferior to medial, which basically means hands in pocket motion direction. Internal oblique is superior to medial, opposite to the external. So the external oblique is coming in this direction, internal oblique is in the opposite direction. Transverse abdominis in the transverse arrangement, which is horizontal. Then you have the rectus abdominis, which is vertical. Okay? Now, what is the rectus sheath? It is the space that encloses the rectus abdominis. It's basically covering it. What is it formed by? It's formed by the fusion of the aponeuroses of the external oblique, internal oblique, and transverse abdominis. So what makes up the rectus sheath? All three of the aponeuroses of the muscles. Okay, it is separated into anterior and posterior rectus sheath. And do you guys know where it ends? The posterior sheath. Where does it end? Arcuate line, exactly. So the arcuate line signifies the end of the posterior rectus sheath. This is really important. Okay, it contains the superior and inferior epigastric vessels, lymphatics, and nerves. Now, above the arcuate line, the anterior wall of the rectus sheath is made up of the external and the internal oblique muscles, the aponeurosis of the external and internal. The posterior wall is made up of the internal oblique. As you can see, it separates here into the anterior and posterior part, the transverse abdominis and transversalis fascia. Okay. As for below the arcuate line, you have the anterior wall made up of the aponeurosis of the external oblique, internal oblique, and transverse abdominis. And posteriorly, it's made up of the transverse fascia only, and there is no muscles. Okay. Now, let's look at it on the cadaver. We have the aponeurosi will form a line in the middle of the abdominal wall called the linea alba. This line right here is called the linea alba. It's made up of the external oblique aponeurosis, internal oblique aponeurosis, and the transverse abdominis muscles, aponeurosis. Okay? Now, what about the linea semilunaris? The aponeurosi will also form a line that is lateral to the rectus abdominis. Okay? So lateral to the rectus abdominis is called linea semilunaris. Medial is called linea alba. Okay? And this is the triangle that we're going to talk about in a bit. Is everything I talked about clear until now? Do you have any questions? Okay. So the inguinal ligament. The inguinal ligament, it extends from the anterior superior iliac spine to the pubic tubercle. So you have the anterior superior iliac spine and the pubic tubercle, not the symphysis, the pubic tubercle. In between them, you're going to find the inguinal ligament. It is formed by the inward folding of the lower edge of the external oblique aponeurosis, which thickens to create the inguinal ligament serving as the floor of the inguinal ligament. So basically, you have the external muscles aponeurosis, okay? You have them going in this direction. On this part, from the aces to the pubic tubercle, it will fold on itself and it will thicken, forming an inguinal ligament. And this inguinal ligament is really important because it basically tells you that above is the abdomen, below you're outside of the abdomen. Okay? So let's talk about the inguinal rings. We have two inguinal rings. And what do they contribute to? They contribute to the formation of the inguinal canal. A canal is basically like a tunnel. You're going in and then going out. You have the opening, which is the entry point, and the exit point. The deep ring, it goes through the transversalis fascia, and it's the entry point. The superficial ring goes through the external oblique aponeurosis and is the exit point. Deep is inside, so it's the opening. Superficial is outside, so it's the exit. Okay? Now, why am I talking about that? Because we're going to come to the Heisenberg triangle. Why is this triangle important? Let's first off know what this triangle is. It's a region of the lower anterior abdominal wall that is described as a potential area of weakness in the abdominal wall through which a hernia can protrude. What is a hernia? A hernia basically is a part of your insides, which in our case is the intestines, bulging through an opening or a weakening. Okay, so either an opening or a weakening in the muscle or tissue that contains it. Okay, so let's look at the borders of the Heisenberg triangle for now. First off, we're going to look at the medial border. So the medial border of the triangle is made by the linea semilunaris or the lateral border of the rectus abdominis muscle. They are both correct. Okay, the lateral border on this side is made up of the inferior epigastric vessels or die, which is the deep inferior epigastric. These vessels right here. Inferiorly, the inguinal ligament that we talked about. Okay, now we're going to talk about hernias. Go back. Okay, we're going to talk about the hernias now. We have two main types of hernias, of inguinal hernias. We have the direct and indirect. What is the difference? The indirect hernia, it goes through both the deep and the superficial, thereby descending into the scrotum. Because what is the inguinal canal? It's basically the place where the spermatic cord goes into the scrotum. So a hernia inside that passes through this canal will end up in the scrotum, and it's called an indirect hernia. A direct hernia, it goes through the Heiselberg's triangle and into the superficial ring. Remember how I told you the hernia goes through an opening or a weakening? If it goes through an opening, which is the inguinal canal, it's called an indirect. If it goes through a weakening, which is the Heiselberg triangle, it's called a direct canal. Okay, let me show you these pictures because it's much more clearer here. So the indirect hernia, we said it goes through the deep inguinal ring and the superficial inguinal ring until it reaches the scrotum. A direct inguinal hernia, it will not go through the deep inguinal ring, it will go through the Heiselberg triangle and then through the superficial inguinal ring. Okay. Now there's really important keynotes that you need to understand. If the hernia is medial to the inferior epigastric vessels or the the hernia is direct. If it is lateral, the hernia is indirect. What do I mean by this? We have the vessels right here, okay? If it is medial to it, means it's medial to it, it's inside of the triangle, then it will be direct or indirect hernia. If it's inside of the Heiselberg triangle, is it direct or indirect? Direct, okay. If it is lateral to the dye vessels, it will be indirect. Why is that? Because it will go through the deep ring. So if you look right here, you have the deep ring lateral to the epigastric vessel. So medial to it, it will be direct, going through the Heiselberg triangle. Indirect will be lateral to the vessels and going through the deep inguinal ring. Okay? If the hernia is under the inguinal ligament, it's not even in the abdomen, then it will be called a femoral hernia, and this is really common in females. Okay? So, question: where does the inguinal ligament attach to? Give me the letters, yeah? A and E, A and D. So the answer is A and D. Why is it not A and E? We already know that A is the anterior superior iliac spine. We said that it attaches to the pubic tubercle. The pubic tubercle is at the front, okay? So the inguinal ligament will attach to A and D. Which one is above the arcuate line? Is it A or is it B? A, A, okay. Why did you answer A? B has no posterior aponeurosis. Exactly. So there is nothing that the muscles have nothing to do with the posterior part in B, because B is nothing in posterior. Exactly. Correct answer. So now we're into the liver and gallbladder. Rida will explain them.
Okay. About this table here, it says mostly mucus. Just want to address it. I searched it up and it's actually wrong. It's mostly serous. Okay. So just want to clear that out. And this question is also right because we said it's serous, isn't it? Okay, now moving on to liver and gallbladder. Okay. So let's start. Okay. So starting off with the liver, let's talk about the anatomy and the structure and everything that's going around with liver, okay? So this right here is the anterior surface of the liver that we're looking at, and it's going to be covered by the visceral and parietal peritoneum, right? The parietal peritoneum folds to create the two main lobes of the liver, which is the right lobe, which is the larger one, colored in the green, and then we have the left lobe, which is the purple one. Okay, the fold between these lobes is called falciform ligament, okay, which attaches to the anterior abdominal wall, just like Adam explained. Okay, within the falciform ligament, there is a remnant of the left umbilical vein. Just to be precise, this is left umbilical vein, which is called the ligamentum of Teres. Okay, so in this picture here, you can see ligamentum teres more clearly than this one. So there's the right lobe, which is the larger one, left lobe, which is the smaller one, and then you have the falciform ligament between these lobes, and then it continues as ligamentum teres. Okay? Okay. Now, about the bare area of the liver, it's the main significance of this is it's not covered by the visceral peritoneum, so it's more prone to damage, okay? And it is in direct contact with the diaphragm. Another thing is the parietal peritoneum falls between, okay, so because it's not covered by the peritoneum, what happens is the bare part of the liver is behind this, right? It's like in contact with the diaphragm, right? So when the peritoneum goes, it actually kind of goes over it instead of like covering it entirely. And that's what forms the coronary ligament there, okay? And the two ends of the coronary ligament are called the left triangular ligament and the right triangular ligament. So they look like triangles. So this is the right one, and this is the left one. And this is the falciform ligament, which continues as ligamentum teres. I hope that's clear. Adam kind of briefly covered the caudate lobe and the chondrate lobe. So the caudate lobe is the superior one, and the chondrate lobe is the inferior one. And this is the bare zone here. This is the inferior vena cava. Okay, these are some important points that they can ask you to distinguish. Okay. For the visceral surface, rougher surface is rough because of the depressions and the vascular bundles, okay? And we said that it contains caudate and quadrate, which is superior and inferior lobes. The caudate lobe is between the fissure of the ligamentum venosum and the inferior vena cava. So this is inferior vena cava, and here is going to be ligamentum venosum, which is not seen in this, but here. So this is your inferior vena cava, and this is your ligamentum venosum, and this is your caudate lobe, which is the superior one, okay? And then your inferior lobe, which is your quadrate lobe, is here. Okay, there between the two lobes you have the portal triad, which with the abbreviation DAV, as you can remember what the triad has. Okay, so there's the portal vein, there's the hepatic artery proper, and then there's the bile duct. Okay, so the cystic duct joins the common hepatic duct to make the common bile duct. So there's going to be left and right hepatic duct that makes the common hepatic duct, and then there's going to be cystic duct that's coming out from the gallbladder, and cystic duct and common hepatic duct together make the common bile duct. This is just like a zoomed in version of the portal triad to illustrate it better for you guys. Okay, this was also kind of covered, but about the Calotes triangle, it's really important that you guys know how to locate it. Okay, so you're gonna have the borders, right? You're gonna have the hepatic duct, the cystic duct, and the liver. So on the cadaver, this is gonna be the liver, right? And this is the gallbladder. Any duct that comes out of the gallbladder is the cystic duct. Okay, so this is the cystic duct. This is, you can see, this right here is the common hepatic duct. So between the cystic and the common hepatic, this thing is the cystic artery here. Okay, and that's how you locate it. Okay, that's about that. For the histo, we know that the liver has capsule plus the visceral peritoneum. We're going to be looking at the triads, the central vein, the sinusoids, very important, the Kupffer cells, and the hepatocytes. Starting off, we're going to be looking at the portal triads. These right here, these small openings that you can see, you can't really, if I zoom in a little bit, you guys can see the white things. These are your portal triads, okay? There. And then this is your central vein. Okay, we're gonna zoom in more so you guys can see clearly. Okay, now we know that the liver is covered with a fibrous capsule, which is called the Glissen's capsule, and the surface of the capsule is covered with the visceral peritoneum, which is mesoepithelial cells. Okay, so this flattened nuclei are the mesoepithelial cells, mesothelial cells, sorry, and this capsule is called Glissen's capsule. It's important to know that it's called Glissen's capsule. Okay, the central vein is at the center. You can see these are the sinusoids that are draining into the central vein. Okay, and the central vein is where the blood flows from the portal triad. Okay, and the epithelium makes the wall of this vein, which is endothelium. Okay, so this is sinusoids, and sinusoids are basically lined by the endothelial cells, which are these flattened nuclei. These ones. I hope you guys can see them. They're very flattened here, just right here, and there's one here. And this entire pathway is called the sinusoid, which is draining into the central vein. Okay, and then you also have hepatocytes all around the liver, like all these cells, which are not flattened nuclei, just like round nuclei. These are hepatocytes, where they're the cells for the liver. Okay. Moving on, we talked about the sinusoid. Sinusoid is basically where the mixed blood comes, which is rich in nutrients, and the wall is made up of endothelial cells as well as Kupffer cells. So there's going to be mixed blood, which is oxygenated and deoxygenated blood that comes in this. Okay, this is where we can differentiate the endothelial cells and the Kupffer cells. So for the Kupffer cells are basically like macrophages, but for the liver. Okay, so you're gonna have endothelial cells, which are kind of like flat nuclei, whereas Kupffer cells are like, they have like a round nuclei, but their cytoplasm is also visible. To not get confused between the hepatocytes and the Kupffer cells, just make sure that you know that they're also along the lines of the sinusoids, because they're lining the sinusoids with the endothelial cells. Okay, so wherever you see an endothelial cells, around them you're going to also see your Kupffer cells. Whereas hepatocytes, you're going to see hepatocytes as a cluster just around somewhere. Like they're not going to be along the line or in the lumen of the sinusoids. They're just going to be like somewhere as a cluster beside the sinusoids, if that makes sense. Okay, so Kupffer cells and endothelial cells, main differentiation is that endothelial cells are usually flattened nuclei, and the Kupffer cells are like macrophages. So their function is basically phagocytosing, and they have like round nuclei with like a dense cytoplasm that you can differentiate with. Also, what happens if the amount of the connective tissue increases between the hepatocytes? So if there is more connective tissue here, that means there's fibrosis, okay? Which is basically a liver cirrhosis. So size of the liver decreases, and so does its functionality. Okay. For the portal triad on the histology slide, it's usually located at the hepatic lobule. And as we said, it consists of the hepatic artery, the portal vein, and the bile duct. The most easy way that you can differentiate this is there's going to be the portal vein, which is going to be the largest one, right? And then you're going to have the bile duct. And as we said, the ducts usually have either the epithelium of simple columnar or simple cuboidal, okay? And the duct is also, so this is like a Mickey Mouse sign, if you guys know, okay? So the portal vein, always to the right of it is going to be the hepatic artery, and always like kind of like a bit basal to it is where it's going to be the bile duct. Also, you can just tell from the location as well as the appearance if it's a duct or if it's a artery. Okay, so the duct is going to be more circular, and you can tell that the epithelium is either columnar or cuboidal, whereas an artery is going to be more of squamous epithelium. Okay, so it's just a differentiation here. And do the hepatocytes secrete material directly into the sinusoids? No, because everything that is going to the sinusoids eventually first has to drain from the space of Dissy, which you can't really see in the histology slides, but for the knowledge, just know that this is the space of Dissy and everything flows from here and then it goes to the sinusoids. So space of Dissy is kind of like a bodyguard, which makes sure that everything is first flown through the space and then it's gone to the sinusoids. Okay? So for the gallbladder, this is the first GI organ where you don't find muscularis mucosa and submucosa. So you don't have a submucosa here, okay? So the type of epithelium for gallbladder is going to be a tall columnar epithelium, okay? And, oh, sorry, I thought it was a highlighter. Okay, and the function is usually storage of bile, but that's not the only function it has. It also concentrates the bile as it's storing it, okay? Which is written here, very important to know. It's not just storing the bile, it's also the concentration of the bile. So the layers of the gallbladder is going to be the tall columnar epithelium, which you can see here. And then you're going to have the lamina propria, which is the mucosa layer. And then you're going to have the spoon muscle layer, and then adventitia or serosa, because it doesn't have a submucosal layer. Okay, so this is just shown like a zoomed out image, and this is a zoomed in. So what's the difference between the layers of the GI tract and the gallbladder? We just said, we talked about it, and we said, okay, there's no submucosa in the gallbladder as well as muscularis mucosa. For the impressions, this is really important, and there's a guaranteed question that something's going to come from this. Okay, so the 5 impressions that you need to know in the liver is gastric, renal, colic, duodenal, and esophageal. Okay, so coming to the impressions, they're really easy once you get your hands on them. So gastric is the larger lobe, okay, which is the right lobe basically. So behind it, it's going to be gastric, okay? And then the renal is going to be much more smaller and it's going to be on the left side. So renal and suprarenal are together, okay? And then gastric is just one whole. And then around the gastric, you're also going to have esophageal, because you know how esophagus comes and then kind of like goes around the stomach, and there's like cardia and then the fundus and everything. So wherever you see the gastric, there's also going to be a bit, this dent that you see here is going to be the esophageal impression, you can see here. Okay, and this is going to be the gastric one. That's the caudate and the quadrant lobe. This is the renal. So this, you can tell that it's shaped like a kidney, it's shaped like a bean. Okay, so this is the renal impression. That's a suprarenal. And beside the renal, you're going to have the duodenal impression. Okay, and below the duodenal is going to be the colic impression, which is basically the colon impression. So duodenal and the colic impression. So these are the, wait, hold on a second. These are the 5 impressions that you need to know. Super easy once you start practicing them or start looking at them. So gastric with esophageal on the right side, and then you have renal, suprarenal, duodenal, and then colic, okay? And this is just to test yourself. I'm just gonna ask to see if you guys can tell the difference. Okay, tell me what this impression is. This one right here. Colic. Okay, good. Tell me what, it's not really clear, but let's say somewhere here should be like a dent. Esophageal. Okay, good. See? And this is renal. This is kind of suprarenal. Then this is going to be duodenum, and this is going to be gastric. This is a slide just for you guys to practice the greater omentum, the lesser omentum, and all of that. Okay, so for cholangiogram is basically where you can, it's a different kind of like different parts of the organ. Okay, so we talked about gallbladder. We said whatever comes out of the gallbladder has to be the cystic duct, right? So this is coming out of the gallbladder. This is the cystic duct. It's joining the common hepatic duct to make the common bile duct, okay? And common hepatic duct is formed with the right and the left hepatic ducts, okay? The common bile duct goes down, forms a pancreatic duct here, like this, and then there's the duodenal blush. That's pretty much it. If they have to ask about anything, they're probably going to ask about cystic duct and common bile duct, a common hepatic duct together forming the common bile duct. So it's going to be like, oh, A, B, and C. So what do A and B join together to make? And what's B? Something like that. For the celiac angiogram, this is basically about the arteries that we took, right? So this is your right hepatic artery, this is your left hepatic artery. They go and they supply the lesser curvature of the stomach. Then you have the common hepatic artery, which gives you your right, first it gives you your gastroduodenal artery, which gives you your gastroepiploic. And then this is your right gastric artery, and this is your left gastric artery. That's right hepatic artery, my bad. Okay, and this is your one second. Right hepatic artery, left hepatic artery gives you your common hepatic, and then this gives you your left gastric and your right gastric. Okay, and yeah, that's all you need to know from this is there's right gastric and then there's left gastric, and then this common hepatic forms gastroduodenal, which gives you your right gastroepiploic. There. Okay. Okay. So that's for the liver and the gallbladder. Do you guys have any questions before we get into the practice questions? Just know the impressions, they're really important in the liver. Know the ligaments, which is the falciform ligament and the ligamentum of teres. What's CA? One second. I know what CA is. Wait. 1 second.
Celiac artery.
Celiac artery. Thank you. Thank you, guys. Okay. And I think this is splenic artery. So celiac artery and splenic, and then left gastric and common hepatic. Okay. Any other questions before we get into the practice questions? These are like the last few slides, so just bear with us. Okay, label X and Y. So this is Y, and this is X. Okay. Okay. What is X a remnant of? Be very specific. Left umbilical vein. Good job. Okay, great. Really important. Okay, here. Name the organ impressions on the red and the green pins. So first green and then red. Okay. Red is renal. Good job. Okay. Name the impression that's shaded in blue. Okay, what is the embryonic origin of this organ? Like, what's the embryonic origin of the liver in general? Ectoderm, endoderm, mesoderm? Endoderm. Good job. Okay. And then we're going to come to ultrasound, where Adam's going to take over again.
Before we continue with the ultrasound, I just opened your lecture, and the major pancreatic duct is the Wirsung, and the accessory duct is the duct of Santorini. Okay, so just go with your lecture, whatever the doctor taught you. But before, okay, let's continue into the ultrasound. Okay. Bismillah. So for the ultrasound, this is literally 3 marks. And inshallah, you get a question about this, then no, it's genuinely 3 marks. From this slide, what you need to know is that any fluid in the ultrasound will appear as black, and it's called anechoic. Any soft tissue will appear as gray, and it's called hypoechoic. And any bone or any air will appear as hyperechoic. You need to memorize the names because they might ask you, what is this structure and what color is it, or like that type of question, you know? So let's look at the ultrasound. Rida talked about the Mickey Mouse. Basically, you have the head of Mickey Mouse, you have the 2 ears, okay? The biggest part is always made up of the portal vein, okay? The biggest part is the portal vein on the left side of the patient. Keep in mind, this is the left side of the patient, which is your right, okay? So on the left, you will have the hepatic artery. On the right, you will have the common bile duct. This is literally 3 marks. Just memorize. On the right, common bile, left, hepatic artery, okay? And just know that the stomach cannot be seen on the ultrasound, either because it's filled up with food and fluid or because it's empty and collapsed, okay? Now, there's another picture that they might get you, which is this picture right here. They might ask you to identify different structures. So let's start with the Mickey Mouse. We have the portal vein. We have on the right of the patient, we have the common bile duct. On the left, we have the hepatic artery. This organ right here is the liver. Now, the liver appears as gray, which is called hypoechoic because it's made up of soft tissue, okay? Then you have the gallbladder, and you have this structure right here. They both appear black, which is called anechoic, and they both appear kind of the same. This is the gallbladder, and this is the IVC. In the exam, 99% of the time, they literally say this every single year. 99% of the time, they will ask you about the gallbladder, okay? But in order for you to differentiate between the IVC and gallbladder, the one that's closer to the common bile, to the portal triad, is the IVC, okay? Because they will literally get the exact same picture as this one. The one that's closer to the portal triad is the IVC. The one that's above is the gallbladder. The one that's closer to the liver, the gallbladder, okay? And remember, the gallbladder is anechoic, liver is hypoechoic, okay? Now, I have a question and I want you to answer it. It's a really short answer, okay? Let's say you are performing an ultrasound. Everything appears normal, but you cannot find the gallbladder. Why is that? Contracted. Okay, nice. So it's contracted, it's empty, exactly. So we said that for an organ or for anything to appear as black on the ultrasound, it needs to be fluid filled. Let's say that the patient ate a meal, okay? You need to digest it, you need to absorb the nutrients in the intestine. So the gallbladder will release the bile into the intestines to help with whatever you guys took in your lectures. I forgot what the function of bile was. So the gallbladder will be collapsed. Okay, it will not appear, it will be empty. So that's why you sometimes may not find the gallbladder in the ultrasound, okay? And yeah, that's basically it. So when you do an ultrasound and you want to check for the gallbladder, you tell the patient to come on an empty stomach, okay? Now, which of these structures carry oxygenated blood, and which of these structures carry deoxygenated but nutrient-rich blood? A is 3, B is 2. Okay, correct. A is 3. So basically, this structure that's on the left is always the artery. Yeah, the structure on the left is always the artery. The structure on the right is always the portal. The structure in the middle is always the portal vein. Now I have a question. It said that it's deoxygenated but nutrient rich. Why is that? Just answer it really quick. It's really simple. It's not a trick question or anything. It's deoxygenated but nutrient rich. Why is that? Exactly, it's coming from the gut. So it's absorbed all of the nutrients from your food. However, it's supplying oxygen to the GI tract. So it's deoxygenated but nutrient rich, okay? Is there another question? Okay, there isn't. So we're gonna move on to anatomy, okay? Now I'm not gonna go into details of every single level because what they told you is that T12 and L1 is the most important, and that's what they mostly test about in the previous OSPEs. And I will also focus on L2 a bit, okay? So let's first off start with the first one, which is T8. How do you know you're in T8? I'm gonna help you differentiate between all of the levels, okay? How do you know you're in T8? You have the heart. If you see the heart, you know you're in T8. Structure 12 is the inferior vena cava, and 13 is the aorta, okay? If you see the heart, you're in T8. That's all you need to know from here. I don't think they're gonna get T8 at all. T9, how do you know you're in T9? You're gonna start to see the esophagus. So basically the esophagus, as you know, is a muscle. So you can see the striations here. When you see the esophagus, you know you're in T9, and you cannot see the heart clearly anymore, okay? In T9, there is something that emerges, which is the esophagus, and you have the liver here, okay? That's it for T9. Moving on to T10. How do you know you're in T10? You can see this kind of blue area, which is the body of the stomach. If you see this blue area, you know you're in T10. And the second that the 7F, which is the stomach fundus, appears, you're not going to know that it appeared. They're not going to get you T9 and then get you T10 after it. So if you see the blue area, a little blue area, then you know you're in T10. Okay? So in T10, what do we have? We have the stomach fundus. We have the esophagus. We have the liver, which is really big. And we have the aorta and the IVC. Okay? The aorta and the IVC. And the spleen is starting to appear here. Okay? That's it for T10. Now for T11, there is no kidneys yet. So the first thing, no kidneys. The second thing, the blue has become more. Okay? So you see the difference between T10 and T11. The blue is becoming much bigger and the fundus is becoming small. And if you look at the spleen, it's become much, much clearer. Okay? So that's how you know you're in T11. You have the stomach fundus, you have the spleen, you have the aorta, IVC, and you have the liver. Okay? Now, for the T12, this is where things get tricky. How do you know you're in T12? Do you see this structure? This is the kidney, right? So if you see a kidney, you're in T12. If you see any form of kidney, you're either T12, T12, L1 or L2. However, there is no hilum of the kidney. What do I mean by hilum? I mean this part of the kidney. You see this part? It's not appearing on that vertebral level. So if I see the kidney, okay, I am seeing the kidney, and I am not seeing the splenic flexure, that means I'm in upper T12. Okay? If I'm not seeing the splenic flexure and I'm seeing the kidneys, then I'm in upper T12. If you see the splenic flexure, you are in T12 in the lower part. Okay? So let's look at the structures that we need to identify on T12. First off, we have the stomach body. Then we have the spleen. We have the two kidneys. We have the aorta. And these are the diaphragm crosses, the left and right diaphragm crosses. We have the IVC. We have the kidney. And this structure appeared. This is the gallbladder. Okay? So you see kidneys, you see gallbladder, you enter T12. Okay? Now, for the lower border of T12, as I told you, you're going to see the splenic flexure. How do you know that you're in the colon or in the large intestine? You can see this color right here, right? You probably know what this color is, but when you see this color in the anatomy page, you know that you are entering into the large intestine. Okay? So you see the splenic flexure, you see the celiac trunk. So we said the aorta is here. It gave us a branch. And what branch comes out of T12? The celiac trunk. Okay? So celiac trunk came out, it gave us two branches. We already know what they are, right? So the splenic artery going to the spleen, which is on the left side of the patient, and the common hepatic artery, which goes to the liver. And we already know this is the gallbladder, this is the liver, the body of the stomach, spleen, and kidneys. Okay? However, there are these really small structures right here. It's better if you know them, because if I remember correctly, we were asked about them before. I'm not really sure, but they might ask you about them. So just know that this is the portal vein and the common bile duct. I don't think they're going to tell you to differentiate between them, but know that this is the portal vein and the common bile duct. Portal vein is closer to what IVC. You remember? The Mickey Mouse, right? So 12 is IVC. Wait, what was it, Mickey Mouse? It's not. Scratch what I said, okay? Don't forget Mickey Mouse for now, okay? So T12, lower border. Let's look at L1 now, okay? L1, how do you know you're in L1? Hilum of the kidney. That's all you need to know. Hilum of the kidney, you're in L1. We have the kidneys, we have the descending colon, and you have the transverse colon, and you have the hepatic flexure. Now, I know it's annoying to differentiate between the transverse, descending flexures, whatever, but if you know which border you're on, and you memorize that on this L1 upper border, I have this structure here, it will be easier for you, okay? So hepatic flexure, transverse colon, descending colon. We have the body of the stomach, and we have the pylorus, okay? So the body and the pylorus, which will become the duodenum later on, okay? This is found in L1. Then you have the pancreas, which is starting to form here. You have the portal vein, and you have the common bile duct. Okay, that's it for L1, the upper border. Now for the lower border of L1, you still have the body of the stomach. You have the transverse and transverse. Okay, these two are transverse colons. The descending and ascending are mostly in the back of your body. Okay, so the ones at the back that's more posterior, these are the ascending and descending. And then you can tell on the right side is obviously ascending, on the left side it's obviously descending. Okay, and the ones in the front, they are transverse colons. Then you have the kidneys. And how do you know that you're in the lower border of L1? You find the renal veins. The second you see renal veins, lower border of L1. The second you see the hilum of the kidney, you are in the upper border of L1. The second you see the renal veins, lower border of L1. Okay, that's how you differentiate between the vertebral levels. And in order to know the structures in these vertebral levels, just know L1 in the lower border, I have 1, 2, 3, 4. Okay, and the 9D, this is basically just like the small intestine, and this is the pancreas. Okay, let's move on. L2, they did not really tell you to focus on L2, but they might bring from it. I know it's kind of high yield as well. So let's look at it. We have the transverse colon from the color. We have the ascending colon from the color, descending colon from the color. Okay, easy. Duodenum and duodenum. It's small intestine. Can you see this? Small intestine. It's like an intestine going around. Okay. 13, you have the aorta and the IVC. Clear? It's really simple. L2 is really one of the simplest ones. However, there is something you need to see here, the muscles. We already know these muscles, right? It's really easy. What's this muscle right here without looking? Wait, let me. What's this muscle? Rectus abdominis. What's this muscle? The plus. Transverse. Then this one and this one is easy, okay? So it's really easy to know the muscles. Let me clear the drawings. Then we go into L3. Yeah, in L2, you are still seeing the kidneys and you can no longer see the liver. So when you see the kidneys and you no longer see the liver, you know you're in L2. In L3, there are neither kidneys nor liver. I don't have the kidneys anymore and I don't have the liver, okay? In L3, what do I have? L3, I have the transverse, okay? Anything that's in the front is transverse, and if it's the brown color, it's the large intestine. You have the small intestine here. You have the, what's it called? The aorta and the IVC, and you have the descending and ascending colon. The descending colon will continue with you until the very end. The second it emerges until the very end, it's always with you, okay? Descending colon, ascending colon, aorta, IVC. Descending colon, this is the ileum, right? Yeah, this is the ileum, ascending colon, and that's it. For the cross-sectional, I don't really think they're gonna focus on it much, but you can kind of tell. Okay, so let's look. Here we have the liver, right? Below the liver, what do we have? We have the stomach and we have the pancreas. What do we have below them? We have the transverse colon. You see how it's opening towards you as if you cut it in half. So let's say you have this tube. You cut it from here, and you look at it from the inside. It's gonna look something like this. Okay, so this is the transverse colon. And what do you have here? Six. Pancreas, we talked about it. What is behind the pancreas is the portal vein. And what is below it, superior mesenteric vein? Okay, yeah, okay, look. They might ask you about this. You have the superior mesenteric vein going into the portal vein. Okay? You need to know this. Superior mesenteric vein going into the portal vein. Okay? And this is the superior mesenteric artery. It's not going to the portal vein. And then you have 15, which is the left renal vein. I'm not going to tell you, ask you about this. That's more renal. Parasagittal. Okay, what do we have here? We have the stomach. We already know this is the stomach. We have the liver. 11, which is the kidneys. Can kind of see the inside of the kidney. It's kind of like that. And you have the transverse colon. You have the small intestines. You have the descending. You see how it's kind of going down? When you see this going down, it's the descending colon. And why is it descending colon? Because if you look at this, they're not going to bring you this image alone, by the way. They're going to get you all three. So how do you know that this is the descending and not the ascending? Look at the line. Okay, it's on the left side, so it's going to be descending. All right, and then you have the sigmoid colon, because if you look at this structure right here, this is where we are. Okay, so this is the sigmoid colon, and yes, that's it for this one. And the right parasagittal, what do we have here? We have the liver, which is really big because we're on the right side. We have the kidney. It's obvious that this is the kidney. We have the pancreas in front of the kidney. Then you have the small intestines going all the way down. And then you have the ascending colon, right? Is this ascending? Yeah, ascending colon. Why did we say ascending and not descending? Because if you look at this picture right here, we're on the right side, okay? When you enter the exam, don't just look at this, oh, what's this, what this? You cannot guess. Look at this picture as well, and this picture, and then you'll be able to answer it, okay? And here's everything I said, like kidneys, whatever, and how you can know the vertebral levels and whatnot. And I have a question. So what level are we in? And what is the structure pointed at with the arrow? And I think this is the last thing we're going to do. Yeah, this is the last thing. First, I need the level and then the structure. T11. L1 descending colon. Okay, L1. Okay, how did you know we're in the L1? That's what I want to know. Because someone answered T11. So why did you answer L1? Hilum. Okay, so if we go back really quick, if we look at L1, I told you, L1, the second you see the hilum of the kidney, you are in L1. Okay, in the upper border of L1. And don't think they're going to ask upper and lower border, just say L1. Hilum of kidney, L1 upper. The veins, L1 lower. If we go to T11, T11 does not have kidneys. Okay, kidneys will appear at T12 until L2, and then they will disappear. And the hilum of the kidney will appear at L1 and the veins at L1, L1 lower border. Okay? Everything clear? Do you want me to go over any one of the cross sections again? Because I think we're done. I think Rida already went over it. Yeah, we're done. Do you have any questions? All
I just
clear?
want to add something.
Yeah, what's up?
Okay, so while I was explaining the histo for the liver, I made a mistake with the common bile duct saying that it's on the left. Just remember that the duct is always on the right. Even if it's the ultrasound, even if it's the histo slides that you want to differentiate in, just remember that duct is right. Duct is right and artery is left. That's all you need to remember, and I think you're going to be good to go.
Yeah, inshallah the exam will be easy. والله يوفقكم. Keep us in your dua, yeah? Best of luck, guys.
Oh, wow.